Great. Well, good afternoon. My name is Mike Bittman. I'm a partner in the Nelson Mullins Orlando office. It's my job to welcome you and at the end of the day to invite you to our wonderful reception. This is a very special occasion for us. We've been quarantined for 3 years and we're coming out of our shells. It's wonderful to see so many friends and clients in the audience, and it's wonderful to be able to bring everybody together. We are interested in interacting and learning from you, as well as our terrific presenters. While the pandemic has changed the world in many ways, we've all worked hard, and we should give thoughts to the caregivers who have taken care of our families over these difficult years. This forum is intended to explore the legal challenges in the new healthcare environment, as well as the new opportunities. So before beginning the program, I have a couple of housekeeping announcements. One is CLE for the lawyers in the audience. We have applied for CLE credit in over a dozen states. At 2 times during the program, I will be announcing a code word that you should retain so that when you do your online survey following the forum, you will get your CLE credit. Also, virtual participants, I encourage you to ask questions in the chat function, and those will be relayed to the moderators. So it's my job to introduce the first presenters this afternoon, John Jesser of Amwell and Trish Marcus, Nelson Mullins partner in Raleigh. Their topic is telehealth and virtual primary care. All the bios are in your program, and I will only add a little bit of color commentary where I feel it's necessary. John leads Amwell, a publicly traded company's strategic clients, focusing on building, partnering, and expanding the Amwell platform for improving patient outcomes, reducing costs, and ensuring the success of Amwell's health plan, critical solutions, and employer clients. Trish Marcus grew up an avid fan of Chicago's sports teams, particularly her beloved Cubbies. You see, Trish's dad, Robert Marcus, was a sports reporter and columnist for the Chicago Tribune for 37 years. In addition to covering the Hall of Famers with the Cubs, the White Sox, the Blackhawks, and other sports teams, Robert Marcus reported on the terrorist attack at the '72 Munich Olympic Games and the Billie Jean King Bobby Riggs tennis match. Although she'll never be in the Chicago Sports Hall of Fame, she's reached the pinnacle of our health law profession by being designated or elected president-elect of the American Health Lawyers Association. So with that, please join me in welcoming John Jesser and Trish Marcus.
Thank you for that. Good afternoon, everybody. It's lovely to be in Florida. Some of you probably live here, but some of you may live like me up in the north. I live in Cleveland, and it was a couple days after Easter, we had 3 inches of snow, and then 5 days later it was 82. And while I'm away this week, it went from 75 back down to 30. So thank you for having me. So I want to spend just a few minutes walking through a few images for you, and then we're going to have a fireside chat and talk about telehealth. So post-COVID, the world changed, and I know you all know this, and it changed in many ways, but in healthcare in particular. I remember in 2012, I was at Anthem Blue Cross, and we introduced telehealth visits. We were going to cover them as a benefit. It was on the Wall Street Journal. It was a big deal. But most people still didn't know what that was. And 5 years later, we were saying someday you're not going to call it telehealth. It's just going to be healthcare. It's, you don't go ATMing, you bank. Anyway, we were predicting all these things, but it was still slowly happening until, the pandemic exploded everything. The use cases for telehealth are incredible. The idea, it started with the idea that you didn't feel well, you were at home, and instead of going to the emergency room, you would, use a phone or a laptop or whatever, and you'd see a doctor within a few minutes. And we were actually able to deliver that 50 states, 24 hours a day, 7 days a week. You could be in front of a board certified, credentialed doctor in your health plans network within 10 minutes or less. It was backbreaking, but we did it. And for many years, that's really what telehealth was. It was avoiding emergency rooms. I'm going to show you a cute little video in a few minutes. It's still very important for that reason. But since then, all of these use cases emerged beyond what we first called urgent care. You have it's spread through Medicare, Medicaid, retail health, kiosks in the workplace, nursing homes, being able to round with a doctor on a tablet instead of having the doctor drive and park. So anywhere somebody would have driven, parked, paid to park, walked, etc., if you could eliminate time and distance as a barrier, there was a way to apply this concept of telehealth. And we're just scratching the surface. The technology has also changed quite a bit. When I started rolling this out, Amwell was our vendor. There wasn't an iPhone app for such things. It was really on a laptop. And then came smartphones, and people don't even, people are not having home computers. How many of you have a computer at home besides your work laptop? A couple, okay. But more and more, the young people, they do it all on their phone. Anyway, so the technology had to emerge. The new platform that we are just rolling out called Converge is completely architected differently because the technology keeps getting better, and it actually sizes itself, whether you're on a phone, a tablet, a computer, a kiosk, wherever you are, it actually will size itself. You don't have to go download an app. We learned this, COVID also brought 50 different solutions out of the woodwork. People were using Skype, they were using FaceTime, things that weren't HIPAA compliant, didn't matter. Anyway, the doctor couldn't get to the office, the patient couldn't get seen. People used everything. So we felt that pressure and created this light, no need to download the app, make it easy, Zoom-like experience. And so that was important. The other thing was adding more capabilities to make care more accessible. We ended up partnering with Google, and Google's working on some amazing, sometimes scary things, natural language processing. If you have Google Home or if you use your phone to ask, I don't even want to say it because my phone will probably light up. You know what I mean? If you say, hey, G, what's the weather going to be like? Or what time do the Cleveland Guardians play tonight? You'll get an answer. They're able to eventually distinguish your cough versus your partner or spouse's cough. That's how they're applying analytics to speech, but they've created some very cool real-time translation. So when you're in a visit, that's the doctor's view of the patient chooses Spanish, starts speaking in Spanish. As the doctor, you're seeing it transcribed immediately in English in a quality, high enough quality to use for healthcare. That's fascinating. The ability to integrate with the EMR, these things all had to happen. You couldn't just it's not okay to just have a video phone. You need to really bring it into the ecosystem of healthcare. So integrating it with an EMR, integrating it with home biometric devices. So if somebody has a sensor, they've left the hospital and they have, the hospital wants to keep track of their pulse, their blood pressure, things like that. There's patches, there's an amazing array of things, almost an arms race of devices and tech that can be used this way. But it needs to all be integrated or they're all standalone one-offs. The platform that we have enables the provider to be able to be a great provider. Let me explain. The McDonald's franchising story, right? The idea was if you can make a burger and fries the same in all these markets, right? There's a lot of science behind that, right? Ray Kroc didn't work at McDonald's, he worked on McDonald's. And you might say, well, a burger and fries is one thing, but that's not very complicated. Look at Cheesecake Factory, 26-page menu, or Fleming's or Morton's. Go in the back and see if you can find anybody over 40, and there's not somebody from the best culinary school there. They found a way, if you're building a restaurant based on hiring the best chef from the best culinary school, as soon as that person leaves, then you're done. So the idea was, how do we create a great experience, great food with a pretty good cook? And I don't want to slight anyone in healthcare or in the medical profession, but you can take a good doctor and give them a great platform, and they can deliver great care. They can close gaps in care. They can make sure that the wellness screenings are done. They can make sure that prescriptions aren't missed, allergies, because you're giving them the tools. And that's part of the back end of this. Again, I talked about you should be able to send a text or an email and get started without having an app to download. Our clients are health plans and health systems, and everyone wants to white label and make it look like it's theirs, as they should. So that we're really a company that provides enabling infrastructure, almost like Oracle or Microsoft or somebody. So they make it look and feel the way they need to. And it also needs to be easily embedded in their website, in their mobile app, not another point solution. Another phrase you might hear is point solution fatigue. Employers have this. They give their employees a mental health app, they give them a diabetes app, they give them a this app and a that. Everybody's got to go to all these different apps. Point solution fatigue. And then we have to talk about seniors. Look, who uses the most healthcare? Seniors. Who's less likely to have an iTunes password and an account and remember the iTunes password? I'm speaking on behalf of my parents, because we've got the instructions written on a Sharpie in big bold letters when they want to use the iPad. It can't be that hard, it's got to be easier. So delivering healthcare to them on their TV, which is often where they're spending time, making it so easy that they can say, hey, whoever, I need to talk to a doctor, or I don't feel well, and maybe their health plan nurse comes up, or their health system, or someone in their doctor's office, or the doctor can say, I'm going to schedule an appointment with you tomorrow at 2, but I'll see you at home. You don't need to come in. This is real. So we've gone from before COVID, replacing a physical face-to-face visit with the idea of a virtual visit. That's before COVID. Post-COVID, it's reimagining the delivery of healthcare, the digital delivery of healthcare. And so one of the things we weren't real good at, we were great at the video visits, but that space in between the visits. Lots of things happen between this visit and 3 months later when you have another visit, or whatever. There's follow-up, there's your vitals. So we actually acquired a company over the summer, and this isn't an Amwell commercial. I'm just trying to give you an example of the stuff that's going on. To do these sorts of things that go on between visits, education. The most expensive part of healthcare is while you're with a doctor or while you're in a hospital, but an awful lot happens in between, and health systems spend a lot of money on trying to call people, trying to follow them. This can all be enabled with technology to reduce. You can have a digital follow-up for patients that can handle thousands of patients at a time without one human having to be involved. Only when there's a need, when there's trouble, and it can be a graceful execution. So here are all the sorts of visits that different, they might need to see a nutritionist, they might need to see a doctor, they might need to see a nurse. But in between all that, they are all kinds of things. Vitals are coming in. Maybe there's an assessment they need to complete. Maybe there's a nudge from their doctor. I ordered a colonoscopy. How come you didn't make the appointment yet? By the way, there's entire programs written around these things, like compliance with colonoscopy. Health systems want to get their patients to have these things. Like 60% of people that schedule, no, not 60%, it's more like 40%, that schedule colonoscopies end up not going. And you think, I know why. It's the prep. No, it's not. It's anxiety, it's different fears about it. They just sort of, but if we've got hospitals that have put programs in place where they're nudging them, sending them messages when they need to talk to somebody, if they really don't want to go, somebody to talk to, and it's drove compliance up. That's revenue for a health system, which is good. It's also important cancer screening, and it's also not wasting an appointment that someone else could have used. So anyway, that's automated care or autonomous care, and we basically have created like a recipe builder so that you can say, okay, we want to do this, then that, then let's have them see a doctor, then for follow-up, let's have them get these three. But you write the recipe. So that's really what we're focused on. With that, I'm going to show you just a quick video, mainly for fun, but it's around that original use case of avoiding unnecessary ER visits for simple things that health plans and integrated delivery systems and everybody's still trying to deal with. This is a commercial that we're putting together with Anthem, and they're going to use it for their Medicare Advantage business, but you'll see the people in the video could actually be over 65 or under, so it could work for commercial as well. Let's see if we can show that video. Sorry, I can't see it. And the issue with what?
Speed. Broadband?
Broadband, but most everything works right now with 3G, 4G pretty well. But as you know, streaming video, sometimes 3G, people switch to just audio. And if it doesn't play, that's okay. There you go.
We're gonna be here all night.
What about that app? No. I put on your phone.
Speaking of broadband.
To see a doctor.
How about we start our conversation? Maybe we can play it at the end.
That's a great idea.
Give you some time. Okay, thanks, guys. It's just kind of cute, the experience we've all had. So,
As John said, speaking of broadband issues.
yeah. Hotel broadband issues.
Right. Well, it's great to have you here, John. Thank you so much for coming to our presentation, to our seminar, I should say, and agreeing to serve as our keynote. I wanted to ask you some questions about telehealth, digital health, Amwell policy, law, all sorts of fun stuff.
I'm not, just a full disclosure, I'm not a lawyer or a doctor. So, all right. Sure, go ahead.
I won't be too tough on the legal questions. One of the things that I wanted to talk with you about is the fact that COVID apparently severely or significantly exacerbated the health disparities that we have seen throughout our country. Apparently, life expectancy dropped by a year for all Americans, but for communities of color, it was 3 to 4 times that. There are a lot of reasons for this, obviously, including access to care or lack thereof, social determinants of health, insurance status, and some others. In fact, the American Medical Association released a report this month in which they made 9 proposals to improve telehealth equity. So my question for you then is, how do you see the use of telehealth, particularly in the primary care arena, potentially addressing and reducing these kinds of disparities? And a related question is Amwell involved in projects that are designed to reduce health disparities?
So yes and yes. In a way, almost every one of our clients is in their own way addressing health disparities. So here's an example. Again, I spent a lot of time on a health plan. This concept of value-based care and value-based primary care network. Let's find these groups of doctors in different markets that are doing quality improvement within their group. They're performing well, and let's reward them. And let's take all doctors and find a way to sort of create some risk, pay them for better performance, and so on. Well, the reality is there's some great medical groups out there, but they're geographically limited to where they happen to be. So if you don't happen to live in, the right part of town or, the right town, the choice of doctors won't be these great high quality doctors, and they'll be just okay. What telehealth and this concept of virtual primary care suddenly does, think about this, you have a 50-state medical group in a cloud. And if that's a quality medical group and they're being measured and monitored and performing at a high level, you as a health plan can now offer that to every zip code in the US. So suddenly, depending on broadband and connectivity, but that's getting better and better. Smartphones are prevalent now with like 85% of the population. I think probably half of those that don't are people like my parents who don't want to, who are flip phone fanatics still. But the point is, the technology, the spread of broadband, the ease of use of the modern phones and tablets, and again, things like home TV, which are emerging, combined with the payer being willing to put these things in the network, suddenly make a network much better than it was. You may have 5 or 6 brick and mortar choices in a certain county, but you've got this incredible group online. Now they can't do surgery. There's some things you can't do with telehealth, but for primary care, for getting diabetics and hypertension patients into care, for having frequency and follow-up and all these things, telehealth or digital care can improve that. That alone is really a strong strategy. And then things like I talked to you about Google Translation, allowing people to, that have language barriers to access healthcare. We identified after thousands and thousands of visits, one hypochondriac, somebody suffering from hypochondria. And guess what? These $49, $59 telehealth visits were actually a pretty affordable way to keep them busy, because otherwise they would have got to the ER, an MRI, and so hypochondriacs aside, people don't want to go spend time with a doctor and talk to them about things because it's easy to do. I think CMS, there's nothing to support that. So where's it all going? The toothpaste is out of the tube. It can't go back, but it's going to be bumpy, and it's going to depend on the individual, those that lead and those that follow. How many people here from health systems? Anybody? Okay. I'm just going to give you a health system Blockbuster versus Netflix analogy here. Toby Cosgrove, former CEO of the Cleveland Clinic, a couple of years ago declared at the Cleveland Clinic, he said, half of all outpatient care is going to be delivered in the home by 2023. That was not just to get a headline. He was trying to light the fire under the neurology group, under the urology group, under the cardiology, because people thought, well, telehealth, that's fine for the urgent care guys, but not for me, for my specialty. Of course not. Basically, he said, game on. Each of you need to figure out a way to deliver care in the home and be practical and be open to it. The other thing was, I love Toby because he happens to be on our board now, but he just had great quotes. Another one was, internally, no one should have to drive here to be treated for hypertension. And then the final one was, I was talking to him about our 50-state medical group in the cloud, and he said, what about a 300-bed hospital in the cloud? So when I negotiated with health systems as a health plan, always on the desk or side table of these, not always, but often, was this architect's rendering or blueprints of the next physician office tower, right? Think about building that next physician office tower without putting shovel to dirt, without a garage, without having to build it. Moving a third of the visits that make sense to the cloud, and think of those health systems that will be doing that versus those that will still be putting shovel to dirt and incurring these huge capital expenses. You're going to end up with the Blockbuster versus Netflix when it comes to their cost structure. So the inevitable, this isn't me, there's no one to blame if you don't like it, there's no one to give credit if you do. It's just going to happen. So the big fat arrow is going to go up. What's the right level of digital versus in person? I don't know. It'll titrate itself. People that are good quality clinical people will figure it out and not make someone drive and park and come in if they don't have to, and the reimbursement will work out so that they'll be rewarded. I talked about how large employers drove the innovation, and then the health plan. For years, health plans would wait till Medicare said something was okay to adopt it. Medicare led. It's the biggest payer. Someone said, well, you guys going to pay for this new therapy? Well, when Medicare does, we'll look at it, right? This is the first time all this changed, and started with large employers and health plans. Again, we made the decision at Anthem to pay for telehealth visits in 2012. Medicare still not sure. The reason it's important though, because Medicare is such a big, heavy weight in this equation. I mean, if a doctor's health system's patients are half Medicare and they're saying no and everyone else saying, so that'll figure its way out, but it's going to be inevitable because the quality, the access to care and the quality are going to be easier to deliver to people by meeting them where they are. I don't know if that covered the whole question.
Well, I think it did. And honestly, we probably, as I said, could go on for another hour or so, but we do not have time. So thank you all so much for your attention. John, thank you again for being here. And sorry, we don't really have time for questions, but I think we'll both be around for at least a little while.
And I'll be around, I think, this evening for the reception that, so just come say hello. Thank you
Awesome.
very much. Thank
Thanks.
you.
Okay, the next panel is ready. So without further ado, this is a serious story that one of our clients went through, and hopefully there's some lessons we can all take from it. Ariel?
So good afternoon, everybody. My name is Ariel Cavazos. I am a health care attorney here at Nelson Mullins, and I'm on the healthcare criminal and civil enforcement litigation and compliance team. I also support our data privacy, security, and breach response team here. I'm incredibly excited to introduce our next session. It's going to be another fire chat session, which will address prominent cybersecurity threats that healthcare entities face around the globe, and is a topic that's on the forefront of many of our clients' minds. We thought it would be interesting to poll the room and see if you guys can spot a typical threat actor trap phishing scam that they use to access our systems and implant malware. All right, so on the screen, we have 3 different examples. The first one is Exhibit A, which is a typical change of password prompt that we all get every 60 to 90 days in your organization. The second one, B, don't worry if you can't read it, but basically it's, as healthcare professionals, we're dealing on a daily basis with PHI, and we usually get encrypted emails and a prompt when you open up a certain document that will say, hey, this is encrypted, click here to open up. And then Exhibit C is the typical DocuSign. So with a show of hands, how many people think Exhibit A is the phishing scam? Okay. How many think Exhibit B is the phishing scam? And then how many do you think Exhibit C is the phishing scam? And for fun, how many think all of them are phishing scams? Okay, who told you guys? Well, anyway, for those who didn't say all, congratulations, you have been hacked. So make sure you pay attention to this presentation. These are typical examples that our clients see on a daily basis. And, when you're going through things at work, it's easy to click on something that could really spiral down very quickly. So it is my pleasure to introduce our cybersecurity panel. Our first guest and friend is Cole Nas. Cole Nas currently serves as the Vice President and Chief Information Officer at Tidelands Health System. In his role, he oversees all areas of the health system's information systems, including clinical and technical applications, clinical and technical support services, infrastructure, telecommunications, and information security. Mr. Nas joined the health system in 2013 and has more than 26 years of experience in the information technology industry and holds over 18 industry certifications. He's a bachelor's degree in cybersecurity and information assurance from Western Governors University. Next is our lovely Gina Greenwood. Gina is a partner at Nelson Mullins, who advises clients across the country and abroad from the Atlanta office. She's the chair of the Nelson Mullins Privacy, Security, and Breach Response Practice Group. Gina concentrates her practice in legal privacy, security compliance, breach preparedness and response, defense, government investigations, and corporate transaction due diligence and litigation support. She defends companies across the industry spectrum and is a healthcare regulatory attorney by trade and a recognized authority in EMTALA compliance, investigations, hearings, and survey responses. She has extensive experience in defending governmental investigations involving immediate jeopardy, licensure surveys, and many other healthcare regulatory operations and compliance matters. With a 20-year experience in data privacy and also healthcare regulatory law, practicing her entire career in 3 AmLaw 100 law firms, she's handled over thousands of security incidents and breach, including ransomware and other incidents, with 100% success rate to date.
Everybody knock on wood, please.
So some of the things that we're going to talk about today may be scary. I know they keep us up at night. However, it's really important to have a really good team in your pocket when you are faced with security incidents. Our incidents response team here at Nelson Mullins is 24/7, 365. We have a hotline that someone will always answer when in need. And we have a lot of bigger source group that supports that subgroup as well. A lot of them here today, so I encourage you to connect with them and make sure that you have the right team on your side when faced with a security incident, most importantly, engaging attorneys for attorney-client privilege purposes. And so without further ado, it is my pleasure to present Case Studies from the Trenches, Ransomware Attacks, Recovery and Prevention with Gina Greenwood and Cole Nas.
Thank you, guys. Appreciate you allowing us to talk to you today about ransomware attacks and cyber events. Unfortunately, I have a lot of job security right now. Cyber events are crazy. There has been a tremendous increase in events. We saw a 400% increase last year in ransomware attacks. Many of you have probably been through the underwriting process for cyber insurance, and you know how hard that is right now, how much harder it is to get cyber insurance than it has been in the past. There's a reason for that. And some of those things that they're asking, those questions they're asking about, all those things are very important to help protect your systems. So I think it's actually a good trend to see some of that underwriting taking place. I am delighted today to be here with Cole Noss. Cole and I got to be dear friends in a major trench, a ransomware attack that happened several years ago. And Cole what was your title back then, Cole?
I think I was a brand new IT manager at the time, just promoted into the role, coming in blind a little bit.
Yeah, I mean, he was just, talk about baptism by fire. I mean, he was thrown into this ransomware attack at a community hospital system.
Mhm.
It's a nonprofit. Cole had done a very good job of trying to get their hospital. They had spent many millions of dollars trying to fortify their systems and put in place many of the things that we're going to be talking about today, and they still went down. And when they went down, buddy, they went down hard. Cole, how long were you guys out in your ransomware attack?
It started mid-December, and to check the box to be back 100% operational was late May, early June of the following year.
So one of the things that Cole and I wanted to do is sort of share, I've represented thousands of clients in cyber events, many of which unfortunately were ransomware attacks. And so as attorneys and people that work in the IT field, it's important to understand how these things happen and how the things that you can do as professionals to, number one, encourage the monies to be spent to prevent these things. Put some time and energy into what would I do in the legal department if this happened to me? How are the things that Cole is telling me, how does that affect the way we respond as an organization? So in a hospital system, Cole, I don't mean to put you on the spot, but hospitals have different kinds of plans in place already. I mean, you take care of patients all day long. The lives of patients are in your hands. And so you already have incident response plans, emergency preparedness, continuity of care plans in place. And can you kind of tell us a little bit about the difference or how some of those things play out from an IT role? Why it's important to think about those things up front before you're in the throes of a ransomware attack?
Sure. Part of it is checking that box for HIPAA compliance, right? Everybody wants to be HIPAA compliant. So you check the box saying, yes, we have these things. That's a stark difference in actual functional documentation, emergency preparedness planning, disaster recovery, incident response. Checking a box is one thing, but having one that's functional, especially unchecked before you're in a malware incident or some type of incident that requires response is totally different. And a lot of folks operate from a business continuity perspective, right? Some things got impacted by this malware, not everything. So let's keep the systems up and running that we have available. Let's not declare a disaster. Let's not shut down and stop work as we know it. And a lot of times that ends up being a mistake. We were very fortunate in our incident because we had invested. One of the first things I did coming in was establish a security program. It was in its infancy, granted, but we had some very advanced technologies that provided some additional layers of protection and things. And part of that was getting a functional incident response plan in place that we knew how to operate. It wasn't perfect, and we learn a lot during these incidents. And I come from a consulting background too, so I've seen a lot of these things play out with other companies that weren't as prepared, that didn't invest the money. But these are all things you think about on the back end, and they're not going to help you in the middle of an incident. So these are things to talk about early on. Get a business continuity plan, decide what the line in the sand is when you declare a disaster. When do you take systems down, the network down? When do you shut down? When do you focus on recovery versus continuity of business? Those are all important decision points along the way, and having a solid incident response plan that you have thoroughly tested, sit down with your teams, have a third party come in and test you, walk through your incident response plan. Those are all important steps to take that a lot of people miss.
Yeah, absolutely. So some of you may be called on to write some of these incident response plans. So we thought it might be helpful to hear sort of the gut-wrenching details of how a ransomware attack happens in a healthcare system and setting. And so Cole has bravely agreed. He's going to undergo some therapy after this, but we're going to take him back in time. Some of you may not realize that your cyber insurance policies may require that you use panel counsel. And so the way I first met Cole, although Tidelands I was at a different law firm. This is actually why I ended up at Nelson Mullins, because general counsel for Tidelands was Tom Moran, who's in this room somewhere. And so I was actually the outside lawyer who happened to be the cyber lawyer that was staffed by the insurance carrier. And so I met Cole and Tidelands for the first time in the worst possible moment you could meet a client. And so I encourage you that whoever you use for cyber response, that you get to know those people before you're walking into a boardroom with them to give a presentation about how your entire system is offline and you've got patients on an operating table with their guts hanging out trying to figure out what to do with those people. So that is not a good scenario. I'm not saying that's what happened here. They were much more prepared than that. But a lot of hospitals, that's exactly what we faced when we walk into those organizations. With Tidelands, I arrived at 2 a.m. After I got the call from, this was Beasley's Cyber Insurance. I arrived at 2 a.m. and I was meeting the CEO for the first time at 8 a.m. And so, that's not an ideal situation. And I can tell you that most panel counsel, they're probably not going to go to the mat for you if you don't have a relationship with them ahead of the time, because they're busy people. And so I encourage you to get to know the people that are going to be taking care of you in the event of having to determine whether there's a notification that has to go out. So I met Cole, and he walks to this board meeting. And by the time I got involved, there were already some communications that had gone out. They were not untruthful. They were actually very truthful. But when you're in the middle of a ransomware attack, and this ended up not being a ransomware attack, it ended up being just a malware attack. But there are certain things, there are ways that we say certain things, and there are ways that we don't. And we have to be careful with the consistency of messaging. And so a lot of times, by the time outside cyber counsel gets brought in, there have already been mistakes that have been made, things that have been said, because the people that are writing those correspondence, they're just trying to calm everybody down. And the problem with that is you don't really know what happened to you yet. And so when you start, you've probably seen this in some of the larger data instances where they'll come out and they'll say, 100 million people, consumers were involved. And then the next thing you know, it's 500 million people. And everybody's talking about, well, are they lying to us? So there's very important reasons. And I know we love the word transparency in healthcare, but there are a lot of reasons not to be completely transparent when you're going through a malware attack. And the biggest reason is the threat actor is watching you. He's watching to see, it's usually the Russians or the Chinese, believe it or not, and they are watching to see what your response is. If you are a state entity and you're subject to open records and you have to approve in open record meetings, which I hope you're not doing this, by the way, the payment of ransoms, they're watching that. Well, it's not, you don't have much negotiation power if the threat actor knows that you've just been approved to pay a $10 million ransom. So these things become very important. And so I want us to walk back in time. And all right, so it was mid-December. Of course, it's always during the holiday seasons. They do not operate Monday through Friday in your non-busy time. I'll just tell you that. It's 4th of July, it's Christmas Eve, it's whatever. This one happened to hit mid-December. And can you kind of walk us through, remember, we're lawyers, we're not tech geniuses. So talk to us about what is this malware that would have been ransomware if it had progressed that far. But what does it do? How do they get in, and what happens?
Sure. I think it's even prior to when it kicked off, right? These are, threat actors are very methodical. They're very thought out in their plan of attack, right? They know what they're looking for. They know how to craft that attack, and it months of planning before they ever come into your network. So, they're going to go to your website. They're going to screen scrape. Who's the, senior leadership? Who are the key players that I want to target? They're doing all of this recon in very public ways, public records, LinkedIn. People don't think about it, but, how much information do you share on LinkedIn? How, is your profile selling your personal data behind the scenes so you can get all those lovely telesales calls out there? Months prior, they're gathering their data, and then they start slowly developing these targeted phishing campaigns, these weaponized, any type of weaponized attachment, right, that they can get through our systems. And they're going to go through phases too. Maybe we have some type of spam filtering service or content filtering service. They'll get notified of that right away. Hey, we tried this, it failed, let's try it a different way. They're going to go through iterations of it. And, through investigations that I've seen in the past from, when I was consulting for companies, you could go back in the logs and see, okay, here was a targeted attack, it failed. Here was one, it failed. And those things add up, and eventually they're going to find a hole. One of the best analogies in cybersecurity that I've heard is the threat actor, us as security professionals in this space, we have thousands and thousands of security holes to patch. There's something like 400,000 new malware variants built every day or every week. So weekly, about 400,000 variants. So we have to guard against all of those, right? The threat actor has to find one hole in your network. That's all it
One
takes.
person.
One person.
Clicking on the wrong email, giving away their passwords.
Yep. And in our instance, it was a weaponized attachment, due diligence on the front end. That's why security awareness training for your customer, your clients is so important, right? That's your front line of defense. People always talk about the end user as our weakest link in an organization. Shift that dynamic a little bit. Talk about them as your front line of defense, right? Educate them up, run security awareness training for them, make them aware of what to look for, these signs. If you have those in place, you're that much more likely to be protected. And that's what it was. It was, a weaponized document came in. As soon as it opened, it kicked off. So going back to your question a little bit, what it was like was what it looked like from my perspective. I was coming into work. We had early meetings. We had a board meeting that morning. We had several things going on. I was on my way into the office about 7:15. My phone just goes crazy. Emails coming in faster than I can process them, faster than I can keep up with them. We had security tools in place that monitor file changes in our environment, file monitoring systems, and it was just firing off, hey, encrypted files detected, ransomware detected. It's just going thousands of emails. Right about the same time, our help desk phones started going crazy. We got the first one about a minute later. We got the first call coming in of hundreds of them from everywhere. It was just chaos throughout the organization. Something was going on. Nobody knew the scope of it. We didn't understand the seriousness of it. We didn't know what to say or how to say it at that point in time. And I think that's the same. I think that's a universal reaction. It's the sheer panic because you don't know the size, you don't know the impact, you don't know the seriousness. You have all these unknowns, but you're in a situation where you have to do something. It's very reactionary. And I think that goes back to the messaging, right? Because you're being reactionary, you have to get something out. We're a hospital system, we have patients coming in, we have surgery scheduled, we have all these things going on already. And to get the call, hey, I can't access my system, sometimes that's a normal thing. Okay, let's reboot, let's do this, that, or the other. When it's hundreds of people, hey, we can't access the system, can't log in, can't do, all these things are happening at one time. It's overwhelming to start.
Absolutely. So operationally, what's happening from what we see in these ransomware attacks is, phones don't work. Our phones run through our computers nowadays. Security systems in hospitals, that's kind of a big deal, particularly if you have like those little babies being born. The machines that are hooked up to people that are being operated on, all that stuff's down. Radiology's down, labs are down, everything's down. And you can imagine your medical staff is not real happy because their revenue is driven and their care coordination is driven off of all those things. And so they're worried about committing malpractice. They're concerned about whether or not we should be keeping patients or deferring them out. And fortunately, when I was working with Tidelands in particular, they had a phenomenal medical staff that recognized these issues very early. And one thing I would like to challenge you to do is talk ahead of time when you're doing your incident response planning. Think about what kind of insurance do we have? Do we have to get approval of the vendors that we're using? So one of the things that we see in almost every case, if the IT folks that are working the attack don't understand what the insurance carrier requires, they're going to start calling anybody they know. They go into panic mode, and they call the people who hook up their systems, who turn on their computers, who might plug them up, or maybe even help them from a technical, installation type thing. That is a very different group of professionals that you need working a ransomware attack. So, but they're just doing where you can imagine. And so just take a few seconds and think about, all right, if this happened at my healthcare system and I was the person in charge of who do we call? I mean, do you have those people on speed dial? Do you know what lawyers to call? Do you know what IT professionals to get in there? And it may not even be your job, but you can bet it will become your job very quickly. Everybody's going to be like, why didn't legal know about this? Why didn't they tell us about all these risks? So it's just really important, I think.
And was IT involved in the decision-making or the conversations when you were developing your cyber policy, right? Knowing, to your point, knowing what's in the policy, who do we contact, what do we contact, what's the protocols, right? I think that's a large gap in this, on our side, on the technical side, is those negotiations happen outside of our privy all the time. I think it's not necessarily that your technical folks are making wrong decisions or bad decisions. They're making decisions on unknowns.
Right, exactly. And they're doing what they do. They're blogging their friends saying, has this ever happened to you? Have you ever heard of, this particular type of file being changed? And that's discoverable information. So getting a hold of those communications and making sure that they have access to the resources that they need access to very quickly can make all the difference from a risk management and PR perspective. All right, so let's talk a little bit about malware and ransomware and cyber attacks. All right, so some of the common ones we see, we've talked about already. We click on an email, it's a link or an attachment, it's got malicious software that launches into the system either immediately or thereafter. Another one that we commonly see is called a credential harvesting scam. And that's where we all get those change of passwords. You saw an example that Ariel gave us. It's time to change your password. And you're putting in what you think is your old password. You're creating a new password. And then the next time you log in your system, you're like, man, that new password didn't take. That should be a red flag to you. You just gave away your password. So in essence, you didn't really change your password. You gave away your password to a threat actor. I would say probably 50% of the cases that we see are those. We also see a ton of insider, very suspicious. It's always amazing to me how the user that got hacked, their account is somebody high up in IT. And so it kind of makes you wonder if that's an insider job. So watch those background checks, make sure you've got people you can trust, but those hackers pay a lot of money for that kind of information to gain access to a system.
Yeah, and back to the initial example, the ABC options, which one of these is a malware attacker, a threat actor? A good point to make there is these people are trying to actively attack your business, your client's business, right? Malware or these threat actors, they're not nice. They're not giving you options, right? They're giving you false choices. What we're starting to see, this was an old practice when viruses were heavily prevalent, late 90s. It's starting to come back around. When you mistype a website, you come up with some kind of crazy pictures everywhere, and it has a pop-up like, hey, click OK to install this, or click cancel to leave the page. Guess what? Both of those options take you to the same place. Clicking OK is the same as clicking cancel.
That's scary.
Either one of them are going to take you to a bad place.
Yeah, very scary. All right, so they get in, either
Yep.
they credential harvested you or they've clicked a bet, somebody's let them in. Usually one employee is all it takes. They get in your systems and what are they doing? Can you kind of explain? We talked a little about recon. So when they first get
Yeah.
in, they're doing intel and recon, and what are they looking for exactly?
Yeah, that's a good question. So again, after they've compromised your system, they're going to do a second round of recon, right? They're going to use all these fancy, network connections and, security or endpoint device that we put in place for monitoring and all these different things, right? Everything's interconnected, and we think that's great, and it's ease of use and functionality. The threat actors are going to use that against you. It just makes it that much easier for them to navigate. So they're going to do a second round of recon, right? They're going to start mapping out your network. They're going to say, okay, I know the server's over here. I know, your wireless network's here. I know this is your SQL databases or, whatever you're running. I know I'm going to identify my targets again, right? So second round of recon on the inside. And they're going to kind of map that out for some time. And that brings you to, what a lot of people do is they'll build out what's called honeypots, right? So it's kind of that false sweet spot in your network that they're trying to get to. Hey, this group of servers, I found their EMR, I found, patient data stored in Excel documents, found all these great things. I'm going to target that, right? But all of that's false information. So it's kind of pushing them there, hoping they'll launch their attack in that environment. So you have time to shore up and secure your actual data. So honeypots are valuable. I think they're underutilized, but they're a valuable piece of your network. But what they're looking for is what's called, technically the crown jewels of the environment, right? They want a high level network or systems person, right? They want admin access to your environment. They want to compromise somebody like that or compromise a valuable server that they know you'll pay to recover data from. That's why they always target your databases and things like that. But they'll do that network map, they'll do the data mappings, they know what they're looking for. And it's important to note, while they're hopping system to system, server to server, node to node, they're dropping little bits of malware, they're dropping downloaders, they're dropping these things, Trojan horses, you'll hear that a lot in these, or worms, they're dropping these things so that when they are ready to launch their attack, they detonate once and it hits every machine that they've compromised at one time. People don't realize that, all these things are happening well before. And we were in the unique situation of having some very advanced tools that could show us in real time what was happening when the malware attack launched. We could see them moving in our environment, server to server. We could see the encryption keys changing as they encrypted files. We could see all these things. We could see them, getting to our data and staging it. So what they'll do is think about like credit card processing, where entity will capture a large number of credit cards for processing. They do sales for a day and they process all of them at midnight. The same thing that these threat actors do. They bundle all this data into encrypted payloads and stage it to be offloaded to batch process out to them at a later date. So we could see that stuff getting staged, ready to exfiltrate, right? So that was the point in time where, and this was days in.
That was not a fun call that I got.
This was many days in and late nights in. We could see this happening in real time. We knew what was going on. And that's when we actively made the decision to disconnect our entire network, become an island, standalone. But at that point, we were isolated. We were in disaster recovery mode at that time. That was the shift from business continuity and fighting this wildfire to recovery. And that's a critical piece for the cyber insurance and your incident response team.
Right. So as hospitals, you have plans in place, or you should, to deal with things like tornadoes, to deal with just under your COPs and all the things that you deal with. You have EMTALA policies that you have to comply with. But a lot of this, if you think about it, is not unlike if your hospital lost power or you got hit by a tornado. But I think so often hospitals don't think about, I need to adopt those plans, not only to comply with the security rule, but to be ready and make sure that our emergency management team knows how to handle a cyber attack, not just a tornado or a terrorist attack on the hospital or something. This is a terrorist attack on the hospital. It's just a different form. And so right now, what we see, what he's just told us is they gain access to the system, they move laterally, they're looking for the good stuff. They're looking for stuff that's got value. They're mapping your system. So from a legal perspective, there are laws out there certain organizations are required to comply with that require them to map their systems. That is a invaluable tool when you're going through a cyber attack or when you're risk assessing in your organization, because if you don't know where your good data is, how in the world are you going to respond to a cyber attack? So what happens on the legal side is they're over there telling you what's happening, and he's now at this point working with geniuses of forensic geniuses who have launched into the environment something like a Carbon Black or a Sentinel-1 or whatever. And that is launched electronically into the environment. It's to clean up. It's got eyeballs on the system. It's all electronic. I just happened to be on site during part of this, but that's not normally the case. Usually all this is done by phone and electronically through the internet. And they've got eyeballs on the system, so they're monitoring. So that's what he's talking about. They not only had it ahead of time when they realized what was happening, but even after that, forensically, when they launched a different and even higher grade product. And by the way, the first one was a product that the federal government uses. So it wasn't like they were using yucky stuff. I mean, they were using top-notch technology. But when they launched that second product in to try to recover and mitigate the damage, stop the bleed and figure out what happened, get eyeballs on the system, that's when he started seeing data being staged to leave the system. And so I got a call. And when he says we shut down disaster, explain what physically happened at that moment. This is my favorite story. What were you doing, Cole?
It was, I don't even remember, 10 or 11 o'clock at night. Like I said, multiple days in, 18, 20-hour days at that point. The CEO, CFO, a few others were in our data center at the time. We saw the data being staged. I mean, I literally ran into the room and I'm like, hey, I'm shutting us down. Nobody's made the decision. I'm making the decision. We're shutting down. I ran back into our data center. I'm literally ripping cords out of our firewalls.
Very sophisticated approach.
It was very, very tactful.
Mhm.
And then of course, you had to get brought in the mix. That's a different level. They definitely escalated. They knew at that time, the threat actors knew at that time we were fighting them. So then it becomes a race. How much data can they get out before we can mitigate the attack? And that's all that it was. It was a race for them to gather valuable data to hold hostage for us to pay them.
Right. So they've done their intel. They knew what they had. They were trying to get the data out of the systems before they truly dropped the ransom payload. So it's several different stages. They're running through the systems, looking at stuff, looking for the good stuff. They're staging data to leave the door, to get out the door so they can hold that hostage and get a big fat ransom payment. But then the third piece of that is then they start operationally crippling the organization. So they run this, what they call ransomware, which is basically this very yucky malware through your systems that encrypts files across laterally. So they're using the same types of technology that we see when your help desk is reaching out to you or when they're launching new software or click here to get your update. It's the same type of technology that they're using to encrypt files all the way across your systems. So they're doing that to kind of get that last punch of we're about to operationally take you out. And so you can imagine if you're a hospital or if you're a manufacturing entity or if you're a school and you're very dependent, or bank, you're very dependent on your technology to make money for that day, to take care of people, to take care of your customers, to meet your consumer obligations. When they have got you crippled and you're operationally down, and there's not a whole lot you won't give them. And so that's what we saw for years. When we first started doing ransomware attacks, I think the average for many years was like $22,000. That was a no-brainer. Pay them, let's move on. They started moving up and up and up as the technology got better where they can actually exfiltrate the good stuff. The ransom payments started going up. So now the average and the Bitcoin payments and all that, the ability to pay. I mean, I remember the days when you would literally drop it in an unmarked something in a post office box. But once the Bitcoin stuff came out, the cryptocurrency stuff came out, it makes it so much easier to be a criminal. The dark web, it gives them an opportunity and a platform to market the data and to threaten you with posting the data to store it. So it's really gotten interesting. And some of the more recent, we always, almost 100% in 2022, see data exfiltration. That was not always the case years ago when Cole was doing this big major case. And so fortunately, he was kind of right in the cusp of the beginning of the data exfiltration. And thanks to his quick thinking and literally ripping cords out of the wall, they didn't leave the building with any good stuff. So that was really good. And the access logs came back really great. So some of that quick thinking before you're in the throes of it would be really great. You know, working with cyber professionals to say, hey, if this happened to us, what would our plan be exactly? And have we run a tabletop? A tabletop is where you do what we're doing. You sit there and talk about it and say, okay, who gets to make that decision? Who has the authority to pull that plug? You know, fortunately, you had this good sense to go do it, but you know, you may or may not have been the actual person who had the authority to do it.
I was not, I can tell you. I was at 11 o'clock at night, that night.
Yeah, and that could have gone either way for you. You know?
Correct. At that point, I didn't care. You know, it's take action, and I'll ask for forgiveness later.
Yeah.
But
He did a good job. So, all right, so we've got him in there. You guys did not end up having to pay a ransom. We didn't
did
even
not.
get that far because he was able to stop it. But in many cases, just so you know, this is you don't want to go to jail. So everybody needs to take notes right now. All right, this is when you go, if you have to pay a ransom, if you're in a situation where you have to pay it, I'm sure you're thinking, I would never pay off those bad guys. I wouldn't do it. You'll be surprised what you'll do when you're operationally down. The years in the past that we were able to pay ransoms pretty easily and get decryption keys were much easier than the times we're living in now. Now there's this little thing, this little war in the Ukraine you might have heard of. Many of the threat actors, so we deal with about 200 different threat actors on a daily basis. People that we are, you know, we can tell by their notes who they are. We know their propensity to do what they say they're going to do, meaning to post data or if we know if they're good criminals or bad criminals, quote unquote. We know if they're going to give you the decryption codes or they're not, all those things. But it has gotten a whole lot harder because of the political environment that we're living in. And you have to consider, you can't pay a known terrorist, right? And so we have threat actors actually siding with Ukraine, China, Russians right now. And it really does make the hair on the back of your neck stand up of, if I'm in a situation where I have to pay this, if they're technically not listed on the OFAC blacklist as a terrorist, so technically maybe I could pay them if I had to, should you? And so there's a process in place in this country of how you protect yourself and your organization, and that process is changing on a daily basis. So I'm not even going to tell you what the process is because you need to call somebody that's read the law that minute. But generally speaking, no, there's a form you have to file with the feds, the FBI, it's an IC3 form. You need to look at the latest set of regs in the industry and make sure that you know what to do before you allow your organization to pay a ransom. And for heaven's sake, work with some cyber forensic firm and attorneys that know what they're doing that can tell you the propensity for the threat actors that you are dealing with. We're at the 5-minute call, so.
and what is from your perspective, I'm sure it's different from on the technical side, but what is the FBI and the Joint Task Force response time in these incidents? What are you finding there? Because I know what our experience was.
What was your experience? Well, should we say that out loud?
No.
We are online. I will say it depends. We have had situations, and there's not a lot of rhyme or reason from the outside looking in. We have contacts all over the country, you know, in all the major jurisdictions that we reach out, Secret Service, the feds, Homeland. And it really depends. I mean, I've had really teeny little businesses that they just jumped all over. You would have thought it was, you know, Coca-Cola went down or something. And then I've had major health systems that we couldn't even get them to return our phone calls. So I personally have come to realize it's a resource thing.
Yes.
None of us are Colonial Pipeline, just so you know, but we are critical infrastructure. And so I think we're going to get a lot more attention, and we have been getting a whole lot more attention lately. But those who think that the feds are going to swoop in and save you, it doesn't happen. It doesn't happen that way. They don't have the resources to do that. They don't necessarily even have the intel.
Well, yeah, I can tell you. I can tell you this part because this is their, you know, rubber stamp response to everything. So the National Guard for South Carolina specifically has a response team, incident response team that they can deploy. When we got on the phone with them talking about remediation, mitigation of this attack, their response was, okay, we can get somebody there on the ground landed to help you recover in the next 3 months.
Yeah, thanks very much. which incidentally was about how long it took you to recover, right?
Yeah, I mean, we had systems up and running in about 2 weeks, but to, be really fully 100% functional back to where we were prior to the attack, like I said, was, a good 5 months, 6 months.
Yeah.
So,
From a legal perspective, and I know we're short on time, but from a legal perspective, when you hear the words backup, I just want you to kind of know they had phenomenal backups. It was one of the things they had spent their money on. And so they were determined to recover and not pay a ransom. And they did, they absolutely did. But standing those backups up, it's not like just a regular EMR system. Everything doesn't just stand up, you push your button there, it's beautiful again. It takes weeks, if not months, to get things moving correctly. And so you'll deal with staff morale issues. You'll deal with angry patients, angry physicians. And we're starting to see a body of cases where, patients are like, I didn't know all this was going on, and I don't feel like I was consenting to remain in that hospital and my baby was harmed or whatever, by that, or by them not having a particular type of technology running. So, the conversation is very much changing, and just know that, and it changes on a day-to-day basis. I know we're out of time. I do want to say one thing really quickly. As attorneys, anytime you have a cyber event in your organization, a phishing scam where someone gets access to an email, some sort of malware event, anytime you have a bad guy in your systems, that is a security incident. You are required by law to research and make sure that was not a big B data breach that requires notification, meaning a letter has to go out to every human that was actually affected by that event. There are about 1 billion other laws you have to consider at the same time. And so just know that a lot of times that piece gets missed. There's a disconnect between IT and legal, or IT and risk, or IT and the privacy office. And so, I think so often we don't want to deal with those IT guys because they're so smart, and we don't talk to them enough. And so we need to make sure they understand their obligations there. I can't tell you how many times we'll get a notification letter from a vendor that they didn't turn into the legal department for months and months and months. The time frame for notification's over. So you just create a really bad risk situation. Anything else? Any final thoughts?
You want to touch on criticality of asset management real quick, or do we want to just jump into questions of asset management?
Oh, yeah.
That piece?
So, yeah, real quickly, we talked about data mapping. Another thing that's critical in these events is knowing what assets you have. It is technically a security rule requirement. It's a legal checkoff requirement.
And where they are.
Where they are, exactly. All those laptops, do they have a list of them? Do they have encryption on them? Because when you're in the middle of a throes of a ransomware attack, if you don't know where your PHI is, or your PII or PCI, you're in trouble, because you don't know which systems to shut down first. You don't know where to go get those laptops to launch the antivirus into them, and it can be a royal mess. So with that, we could talk about this all day, but we're around all weekend, and we appreciate your attention. Thank you so much.
Thank you.
And I'm Jason Epstein. I'm the head of the technology and procurement group for the firm, and we do a lot of health IT and technology. And one of the interesting things about Health Trust is that they're a GPO, which, does everybody know what a GPO is in here? Some people do, some people don't. For those of you who don't, it's basically a Costco. Think about it as a Costco for hospital systems and others, where Health Trust would pre-negotiate deals, with imaging system companies, other vendors, trying to sell on their terms and conditions and pricing. And then if you're a member of that GPO, group purchasing organization, you get the benefit of what Health Trust did in terms of negotiations and pricing, and then you can buy under those terms. So when we go to Costco, we get better deals on 9,000 rolls of toilet paper because Costco did that deal, right? And so we go and get the benefit of what Costco did. That's what the GPO does. And it gives, a GPO has, I would say, a very unique insight on what's going on in the market, specifically with respect to med devices, because it sees so much volume. All the vendors want to sell to all the members through the GPO, right? Because it's a major distribution network. So Health Trust has an opportunity to do large deals with very large vendors with very sophisticated deals, including medical devices, pumps, imaging systems, whatever these things may be, and has a unique opportunity to see what's going on in the market, because they have all these deals and you can almost side by side them, right? Very unique real-time data. Let's start off. There you go. Let's start quickly just talking about impacts and lessons learned from COVID-19. Some of us have experienced this, and we'll be able to talk about some specific contractual negotiations that I think are interesting. But one of the things we wanted to start off with was if Eric, you can tell us maybe about some new collaboration opportunities that arose out of COVID-19 and that circumstance.
Yeah, we really benefited from the pandemic in a good way. In that we developed a partnership globally with a company called SAS. I don't know if you all have ever heard of them. They're one of the largest analytical companies in the world. They're based out of Cary, North Carolina. And with that global partnership, I mentioned the IT vertical that I've got in the business. They're going to be running all of the analytics, both real time, and we talked about predictive analysis as well, AI data within the analysis run. And so from our standpoint, having that global partnership, pulling in our information from our test device, but also pulling in any of the monitoring devices, really will build a perfect picture, perfect kind of avenue for those physicians, those practitioners, either here in the United States, but also globally, where we can go to a Botswana, we can go to a Madagascar, Brazil, and basically train practitioners to be basically trainable on the devices that we're providing to them, but also the other IoT devices that we'll be actually complementing within our IT system and train them real time, but then also make sure that that project that they're working on, that device that they're in that clinic or in that setting is working properly, which is of huge value as well.
Well, thank you for that. And as you know, or may not know, when lawyers do, how many are lawyers here, by the way? We got a lot of lawyers. Okay, so half of us in here deal with force majeure provisions all the time, and the other half probably do, but don't know it's called force majeure, or maybe you do know it's called force majeure, which usually is referred to as things like acts of God and other things. But, you know, lawyers, we have oftentimes what are called boilerplate provisions. Sometimes they're in the miscellaneous section. And you'll be doing deals, and in 10 years, you'll use the same words over and over again. And it's 10 different miscellaneous clauses. And every once in a while, something will happen that will challenge that lingo that you use and didn't really think much about in these provisions. And one of them was, of course, COVID-19, right? Because what happened was there was a lot of vendors and buyers who couldn't perform or claimed they couldn't perform because everybody was sick, right? They weren't available. That gave a lot of focus, right, Lori, on the concept of force majeure. So what were you seeing at Health Trust? Because you have sort of a unique, you have so many vendors. What were you seeing with COVID-19 and the impact on that?
Sure. So when COVID-19 hit, it really impacted, of course, all of the hospitals right away and what they were seeing. So half of my company and teams went out and were actually trying to cold call procure with vendors on N95, those types of things. The other part of what my team was actually doing was dealing with the suppliers. We were having a lot of suppliers coming back and saying, we can't commit or we can't agree to the fill rate requirement that you have in your contracts with us right now. We don't have the products, and we are claiming force majeure. And we were saying no, because we have found in the past that really the force majeure only really helps the suppliers. It doesn't really help our customers, our healthcare providers, our hospitals. And so then we were digging through our contracts, which ones have a force majeure clause. Of course, we have agreed at times when we've had to with leverage and things like that with our suppliers. So then we were trying to determine which ones had it in it. And so then we went back, I talked to Jason at Nelson Mullins, and we were trying to figure out what exactly was okay and not okay and what was enforceable. And thankfully, we found that you really needed to have the word pandemic in it for them to be claiming that in there. And that was really, really important. So we went through, what could the vendors claim, what they could not claim or whatever. And thankfully, for the most part, we actually, held their feet to the fire and said, no, you need to provide us with things. We have a commitment with you. And so the force majeure clause, thankfully, because we either didn't have it in there or didn't have the word pandemic in there, but was really helpful. But going forward, every vendor now is coming back wanting a force majeure clause in their contracts and wanting pandemic. So depending on what side of the fence that you're operating on is whether what you want in your contracts. And if you're dealing with your hospital customers or those types of things, I would highly recommend not having this in there and pushing out, not having pandemic in there and those types of things. So.
How many people did the 50 state surveys for how courts in 50 states interpret force majeure clauses and what you need to do? Well, because we did a lot of that, right? And it crossed industries. It wasn't just healthcare. It was in the hospitality industry. But you can imagine hotels like this, right? A lot of companies have contracts for conventions and things, and they weren't happening, and that was a force majeure event. Do you still owe the money? And you could, so you name it, across the board, force majeure, the concept of force majeure in the pandemic was implicated. What I think is very interesting is, and so basically it goes back to this boilerplate provisions. Some had the word pandemic, some didn't have the word pandemic, some weren't in the agreements at all. So this boilerplate, the lesson here just generally is that, you know, sometimes things aren't really boilerplate and they matter and you got to come back around. What I think is really interesting about force majeure is when you go and do these state law analysis, you determine that one of the key elements of a force majeure event is foreseeability. In every state, could you have foreseen that would have happened? And if you couldn't have reasonably foreseen it would have happened, it could qualify as a force majeure event, right? Well, now the pandemic has happened. So what we're seeing is negotiations where vendors, in particular, people who the obligation would be to perform, are saying, hey, we got to put in a force majeure event for a pandemic. That really begs the question, doesn't it? Well, we're in a pandemic. It's foreseeable that there's a pandemic. So why do you think that makes sense to put in force majeure when force majeure is only for things that aren't reasonable, foreseeable, and we're in a pandemic right now? Can you tell me that? So that's a spirited discussion. So one of the things we actually talked about was, one of the vendors made a good point. They said, well, yeah, we're in COVID-19, but what if it's worse than COVID-19? Because there's a pandemic that could even be worse. So in that deal, we negotiated COVID-19 or a similar pandemic will not be considered a force majeure event. But if there's something materially greater, it might be. Okay? Because basically the bottom line is all businesses have to learn to live with a pandemic and have backup disaster recovery plans, contingencies to address the force majeure issue. So this goes to, by the way, the next issue, which are contract languages, how, and with respect to medical device in particular, how do you hold the feet to the fire to vendors and buyers to continue to perform in things like a pandemic? And here's the next thing. So there are some key issues that happen and you deal with when we talk about medical devices. It used to be medical devices weren't network enabled. They weren't Bluetooth connected. Right? Everything was hardwired. It was at the hospital. You didn't have to do that. We also heard one of the speakers saying that one of the former CEOs and now on his board, 50% of care that's given in hospitals today will be at home, right? Whoever, we represent some of those companies. The next billionaires are people in fintech and the healthcare companies who have built out JVs and companies that are going to deliver care at home. That could have been in hospitals, but now we're going to be in the home. Okay, there's a lot of medical devices and there's a lot of connectivity that has to happen in there. And whenever there's connectivity, there's software issues, there's vulnerabilities, etc. So let's start with Lori. How does, with respect to privacy and security, for example, specifically, what is HealthTrust seeing? And what approach has it taken to address those types of issues?
Sure. So a lot of our members were really concerned over security issues with tech-enabled equipment, and more, we had a lot of contracts with software terms and conditions in them, but they weren't robust enough at the end of the day and didn't address any security concerns because most of the equipment maybe 10 years ago, as we're sitting there negotiating terms and maybe extending contracts out, didn't have those types of things in it. So as their software is becoming more and more prevalent in the medical devices, it was really becoming an issue and a concern. And especially when you're having medical devices that are actually touching patients. And we use an example of, that there's software when you're getting pharmaceutical drugs in you in the hospital. Well, think if somebody hacks into that. I mean, you could kill lots of people, different things are happening and all of that. Robots are touching you in the hospitals. And so we started to create an information security agreement, and we took 5 of our biggest members and what their concerns were and their terms and conditions. And we worked with Nelson Mullins, pulled together one contract that was pretty robust. But in the meantime, we needed something on our contracts that was really on a contract by contract basis in the meantime, as we're pulling all that together. So we did an information security exhibit, pared down the terms and conditions that were needed, and pulled that together. And so, but the bigger thing is for the information security agreement, it's a standalone document. And one of the biggest concerns for us is that a lot of the vendors wanted to go and pull together for their product in whole, including security issues and software and everything. They wanted to, and even privacy issues under a business associate agreement, they wanted to have their terms capped and liability capped and everything. So we keep those documents separate. A BAA is separate from an information security agreement, is separate from the actual purchasing agreement. So it's very clear that if there's an information security incident, that the indemnification and cap on liability issues and risk for the vendor are solely in that contract. Whereas when we were doing it on a contract by contract basis, for the information security exhibit, we still had some risk there, but at least we were capturing something. But we go to the vendors as a whole and we create the information security agreements there. And so it captures everything and all products and services that our members are getting from that one particular vendor.
And it's also an interesting strategy. And we see this with clients generally, which is sometimes the vendors will try to provide their paper, right? Depending on the leverage, and Health Trust has a lot simply because of the buying power, the purchasing power, right? What we're finding in the market generally is to have one side outside of a BAA, but on top of that, a security information protection agreement or privacy and security agreement that's an omnibus agreement. It's not an exhibit to a document. It's not an amendment to a document. It's a standalone document that governs the whole relationship between the parties, separate from, like Lori said, the purchase agreement. So Eric, another key issue in connection with medical devices and healthcare tech is AI and data management and mining. Maybe you could tell us a little bit about your experience there.
Yeah. How many of you all have Apple iPhones? Raise your hand, please. Keep them up, okay? How many of you all have Android or Google? Raise them up. Okay, so pretty much everybody. So then the next question I have, how many of you believe that they do not have any information on you? It's key, isn't it? I think that's the real big takeaway. Where is the data going? Obviously HIPAA, GDPR, when you're looking at that aspect of things, that's a key element. Having systems that are wrapped around that is hugely beneficial. I mean, you look at an AWS system in general, that will have your HIPAA and GDPR guidelines. You look at Azure, same thing. That's great, but then you've got to take it the next step and see where and how is the data being de-identified? How is the data being secured? How is the data being moved? Those are some of the aspects that you've got to think about when it comes to healthcare and IT. The other, I guess, key aspect is where is the true ownership? Again, I'm sure all of you here, we're here in Orlando. So you've got Orlando Health, I live in Atlanta. You've got Advent Health. Those are two of the big ones I know of here. Up by me, it's Emory, and Piedmont and Northside are the 3 up there. They have their own individual healthcare kind of boxes, I guess is the best way to put it, where if you go to Advent Health, you can't really move your data back and forth between Advent Health and Orlando Health. So that's sometimes, I think, a big issue, especially when you're going from a cardiologist at Advent Health to a primary care at Orlando Health. And so moving that data and having it succinctly move from a security standpoint and making sure that your data is not being compromised is something to really be a major consideration. From an ownership standpoint, that's kind of where we're taking it kind of to the next level. You look at your Googles, your Facebooks. Elon Musk now is opening up the door when it comes to Twitter and opening up kind of that free speech enterprise. We are, as a company persona, looking at the aspect of true ownership of the data to allow you to push and pull data as you direct it. And I think as we move forward into this healthcare space, post-COVID, again, we're still in COVID, but less COVID, I guess. I think it's going to be a much more impactful IT scenario from a health security standpoint.
Thank you, Eric. So any questions or anybody have any food for thought on any of what we're talking about so far? Every once in a while, when you plan to give a presentation, something serendipitous happens. And in this case, we're all lucky. That's geeking out, okay? Because the FDA just came out this month with its updated pre-market cyber guidance for medical devices. That's substantial. The last time they did that was a long time ago, almost 10 years ago. And so now people who are in this field, right, are digesting what that means from the contracting standpoint. What is the FDA concerned about with privacy and security and software in connection with medical devices? They're starting to get up to speed, and it hasn't been made final yet. It's open for public comment, but clearly it's going that direction. And we wanted to talk about a couple of issues that's in that guidance now. And actually, you'll see on one of the slides in the presentation, you could just look it up, but that's the further reading slide. We're going to talk about everything else, and it's not worth reading. But this slide right here is a slide that's probably worth reading, and if you wanted to go to it, feel free to do so. And I'm pretty sure you can have access to the slides through some ways or means. But one of the major issues when it comes to the FDA that they didn't have before, that they now define as this concept of total product life cycle. When you buy a piece of imaging equipment, it's useful life, right? Could be 8 years, 10 years. Well, that's a long time in the tech space, right? How long are you going to provide security updates? What happens to the third-party software associated with it? What if that's not updated? It's basically taking a holistic view of maintaining the useful life of a med device, not just to be able to use it to perform its function, but to also make it cyber resilient, what they're calling cyber resilient. Of course, these are just guidelines, right? The FDA comes out and says, these are not law, these are guidelines. And everybody takes a look at that and says, well, how can I do something contrary to what you said you ought to take a look at, right? So I'm not going to say they're de facto law, because they're not, but they're kind of de facto. But Lori, when you see, what do you see with vendors trying to rely on, for example, the FDA guidance and what's Health Trust, what's your experience with that?
Yeah, so our team right now is having issues with vendors relying on it wholly, and they're really pushing back. When we're sitting there asking for a security patch and having it done within 30 days, that's a need that we have and our members have, and they're saying, well, the FDA guidelines don't have that, so we don't need to rely on that. And we're saying, well, it's a little bit different here. We really need to have this. And so we're really finding in general, even with this and in general, that our vendors are really treating everything like it's in a commercial space and not that they're in healthcare, and they really need to get on board and understand that you're dealing with healthcare, you're dealing with patients. And, I had a boss one time tell me, welcome to the NFL. And when you get into this space, you need to understand that you need to take on liability because you're actually touching people, and it's not just a laptop. You're actually physically touching, a patient, a person, something could happen to them. So for these, we are really pushing back on what the requirements are and what the timeframes are. And because the vendors are trying to rely on this FDA guidelines, we're pushing back heavily on that.
And one of the key things in healthcare that's differentiated from just pure data loss, it used to be when you had security breaches, everybody was just worried about their data, personal data. Could be Social Security, could be whatever. Healthcare is the next level, right? Because it's that, but it's also patient harm. It's when these med devices are hacked. What could someone do to those devices or that data to actually cause injury to you? And one of the evolutions in the definition of patient harm is in this new FDA guidance. The old definition, the old guidance about 10 years ago actually didn't have a definition of patient harm. It had the definition of harm, and it was defined as physical injury or damage to the health of people, property, or the environment. So think about that. People, property, the environment. Of course, we all know with respect to people, it's not oftentimes just the physical injury, but the psychological and emotional harm, right? Lawyers are really good at emotional distress. bringing those cases and defending those cases, right? The new definition of actually has a definition of patient harm. It's injury or damage to the health of patients, including death. Injury to the damage to the health of patients, including death. That means that the FDA is recognizing that if you don't do what you're supposed to do with the medical devices, it could result in death. That's a little different than just worrying about even your social security number. I mean, you could have financial ruin, I suppose, but at least you're alive, right? So that's one of the differences in healthcare when you're dealing with medical devices, and the FDA has now even recognized it. Patient harm is actually the greater focus than just personal data. And so there's also real business implications here. So without naming names or describing kind of what actually happened and with whom, imagine buying, let's just stick with the whole imaging, since that's a common motif I can't seem to get off of. So imaging system. 8 years ago, the operating system for this imaging equipment is Windows 7. The useful life of that equipment is 10 years. So everybody knows what operating system is, right? You know, Windows 10, Windows 11, like your computer can't run without it. It runs the system. And I don't know if you all notice, but every once in a while, those OEMs, whether it's Linux or Windows or whatever, they'll have security patches and updates to functionality and error corrections, right? So in other words, to be able to use what you're using, it's not just the software that you click on, it's the engine underneath it that makes everything run. It's called the operating system. What happens when Microsoft says, I know we sold Windows 7 to you on these $2 million pieces of imaging equipment, but guess what? We're going to sunset Windows 7 and you don't have any more support for that. By the way, it's going to cost you hundreds of millions of dollars because you're going to have to buy Windows 10. So you're in a rock and a hard place, right? Hospital systems don't have budget for that, but you can't have access to a network-enabled medical device that is vulnerable because the OEM that runs the operating system isn't doing patching. So all of these things go into this concept of total product lifecycle management. And when you do these deals, you have to think about all the third-party products, software, et cetera, and not just the main piece of equipment, but all the components of the equipment. And they all have to stay updated and maintained and not vulnerable, or guess what? You don't get what you bargained for. Taking imaging equipment offline is not a reasonable mitigation, right? Oh, it's not patched, so don't worry about it, just unplug it. Like, that's not very practical. All right, any questions? Any thoughts? All right, let's move to some opportunities outside of the United States in connection with this, Eric. So you have some opportunities that you wanted to talk about in connection outside the United States.
Yeah, how many of you all are doing any type of global work now? Anybody here that's doing anything outside of the US? Okay, I'll talk short. Yeah, I think for us, a couple things. Obviously, with the SAS partnership and what we're doing on the IT front, they have connections globally to about 120 plus countries. They're tied into about 80 different health ministries around the world. So for us, that door to open from basically them is going to be huge. But really, I think where I guess going back to the safety and security aspect is a key. It's which countries you go into, what are their rules and regulations. Obviously, we've got the FDA here in the United States. You've got the CE designation, which is the EU approval designation over in Europe. And then the separate is the UK. And so those are pretty standard, but you've got a lot of countries in between that don't have the standardized rules and regulations where they actually do their own thing. And so when it comes to that, what does that mean? Where does the data go? Who holds the data? And how is it transferred? I think that's something where from a global standpoint you have to really take into consideration. And then I think last, just to kind of move on to the diagnostic side, again, same thing that we just talked about. There's rules and regulations on what is needed within a diagnostic product as well. And so knowing that up front, based on the country you're looking into, is a good benefit to really take hold of. I think what's really valuable for us and me as a company is the U.S. Commerce Department. They've got a lot of avenues where they'll give you insight on some of the countries that are good to go into and some of the countries that are bad to go into. But they're also kind of look at, and this is probably good for you if you all ever go globally, they'll look at vendors. So they'll see which vendors that they've had good experiences with and vendors that they've had bad experiences with. And so that also helps. So if you ever do have any work to do globally, U.S. Commerce Department is a great asset.
So Lori, what does Health Trust do in terms of its documentation as these documents sort of evolve over time? Like how often do you revisit these new technologies and new laws like CCPA and software as a medical device? What's your basic position on the evolution of your security agreements and vendor questionnaires?
Depending on what it is and how much change, I mean, it could take up to 3 to 6 months just to be updating the document, have everybody vetting it, those types of things or whatever. So I would say between 1 and 3 years, depending on what the document is. Probably our standard purchasing agreement probably only gets updated like once per year, but once every few years generally. But our software is really getting updated almost real time as needed, but really I would say maybe once per year. The security agreement, I would say once every 2 years or so. We've been updating those just to be not only in compliance with law, but also to be what's going on in the industry and make sure we're at the forefront of what's going on to protect our hospitals, patients, those types of things.
All right, thank you. And maybe we can leave on this in terms of predictions for the next decade, which is difficult to crystal ball. But Eric, what about collaborations, in particular with health-related foundations?
Yeah, how many of you are familiar with either a program-related investment or a mission-related investment, PRI or MRI? Interesting. Wow, okay. So one of the aspects from a foundation standpoint, what we're looking at, one of the good kind of stories behind it is there's a pharmaceutical company called Vertex. They brought a drug out into the marketplace for cystic fibrosis. And so what happened there is that they went to the CF Foundation, and through the CF Foundation, they initially put in, I think, around $3 to $5 million to start the process of getting and formulating that product to bring it to commercial market. Ended up where they got back about 19 million out of that, so not a bad rate of return. They ended up putting in another 45 million, and then ultimately got 3.3 billion back. And that's a great, obviously, example of what basically a PRI would be, a program-related investment. So it came from the CF Foundation into a commercial organization. One of the things we're looking at is doing the same type of thing, where we would have a foundation come in, be it a breast cancer foundation like Komen, or let's say oncology, prostate cancer group, or potentially even a neurology group that works with concussion for our platform. Have them do either a PRI or MRI, and then basically through a royalty rights agreement, similar to what Vertex did, basically have an outcome that would be benefiting to that foundation. And so it does two things. It obviously gets the foundation involved in conquering and really helping to eliminate and minimize a disease, but it also progresses through a process of commercialization. So going to these foundations is hugely beneficial for a commercial organization like mine.
So I'll speak a little bit to obviously the governing body, turning the attention to the FDA again. The governing body of medical devices is obviously the FDA. And so, like I said, for purposes of this discussion, the new the pre-market guidance has a lot of it. It's about 50 pages, and it has a lot of good topics and information in there. But like Lori said, it's general guidelines, right? When you're in the trenches negotiating these things and there's a breach, you want to know how many days will it be till it's up and running, right? You're going to want to know what's the process to notify people. It doesn't really cover that. It is general guidelines. There's also another move generally with the FDA about artificial intelligence and machine learning. And the FDA has also come up with medical device action plan. They came out with that in 2021. But other than that, haven't really promulgated as many rules as they have with respect to cybersecurity. But as Lori was saying, as the technologies continue to evolve, and as Eric was saying, you have AI, you've got machine learning, you got software as a medical device, you have network-enabled medical devices. It's kind of like Fletch. Remember, anybody remember Fletch when he goes, it's all about ball bearings? Did I just date myself? It's all ball bearings. Remember, he's in front of it. It's not important right now. Okay, what is important is it's all about tech, privacy, security, artificial intelligence, software as a medical device. And what we think of as medical devices, the imaging equipment, again, is we've gone well beyond that now. So we're all going to be staying on top of these issues. It's a very exciting area of practice. It never gets boring because there's always new things going on. And we hope you enjoyed the presentation.
All right, for those of you applying for CLE credit, here's your first CLE code word. I'll say it 3 times. Interaction. Code word interaction. Interaction. So this is one of my topics that I work with pretty frequently. Prevention of whistleblower and retaliation claims.
Yep. Good afternoon, everyone. Today, we are going to speak to you about whistleblowers and retaliation claims. So when we thought about this presentation and looking at it from an employment perspective and looking at it from a risk management perspective, one of the common things that we thought you would be interested in is we know that you have been through so much already. So we made this, you know, if you look at this graphic here, you've been through just so much beyond. And I see some clients here today that I've, you know, walked through the COVID issues with them and walked through the vaccine mandates and just challenges. And as if you didn't have enough to worry about, we wanted to remind you about whistleblowers and retaliate, to keep your eye on the ball. And we congratulate you for navigating all of those challenges with such integrity. But we're just going to remind you that don't take your eye off the ball. And I'm an employment defense lawyer, and every single employee is a potential plaintiff to me. So we're just going to give you some reminders. And Bart is here, and he is just fantastic with the False Claims Act and whistleblower retaliation investigations. And I'll let Bart introduce himself, and then Ariel.
Okay, I'm Bart Daniel. I'm in the Charleston office and the Columbia offices of Nelson Mullins. Early in my career, I worked in law school at the State Attorney General's office. When I graduated, I was hired as a white-collar prosecutor. I did that for 2 years, and my boss went to the U.S. Attorney's Office, to the feds in South Carolina, and he sort of dragged me right along. I was holding on to those coattails as tightly as I could. And so I was a federal prosecutor prosecuting white-collar cases, including fraud cases. And I want to talk to you about that a little bit when we start in the substance of the program. And I was with the feds for 4 years, and I went into private practice on my own as a sole practitioner for 3.5 years, doing exclusive, not exclusively, but mostly white collar and some business litigation, but primarily white collar defense. And then I went back to the U.S. Attorney's Office appointed by the first President Bush in 1988 and served from the beginning of 1989 until 1992, then returned to private practice. But I've always done, from the time I was in law, well, I graduated from law school, I've always done white collar. And of course, the emphasis, we wrote 3 editions of the healthcare fraud and collateral consequences. We just finished our 3rd edition about 1.5 years ago. So healthcare has been a busy ride when you're any kind of healthcare defense work. I know you guys out there, you've got so many pitfalls to worry about. So that's sort of my background, and I'm looking forward to sharing with Ariel and Kristen.
And I too, I'm sharing the stage with these 2 esteemed litigators that I actually have admired for some time now. But I, in my recent past life, I was partner here at Nelson Mullins, and so I see a lot of familiar faces, and I am excited to be here today. But now I am senior counsel at a company called BioCris Pharmaceuticals. And our company is we focus in rare diseases and the development and research of oral drugs that target rare diseases. And so I partner with HR. I'm the executive partner for HR as well as litigation. So in my past life, I was a litigator through and through, business litigation. I dabbled a little bit in healthcare litigation, but now that I'm on the flip side, I just have a whole new perspective, and I'm happy to share it today.
Okay, you want to go to the next slide and
So jumping in, We're just going to jump into federal whistleblower claims as well as retaliation claims. And when you think about these claims and considering them, you have to kind of go through the history, if you will. There's a convergence of key TAM laws that have evolved over time to incorporate whistleblower protections as well as retaliation claims that can be brought as an independent cause of action, along with the False Claims Act, which Bart is going to go into great detail on. But what I wanted to kind of start with was the foundation really quickly. So I'm going to set the stage. It's 1777. There are 10 sailors in the Navy, and they want to bring a claim against the highest ranking official in the Navy, the Commodore. His name was Essex Hopkins. And so the claim is because they feel that he's unfair, he's treating them poorly, he's a poor leader, he has been charged with, in their eyes, they've alleged that he has ignored the preset orders and rules. For instance, he's treating prisoners inhumanely. So what they want to do is they want to go to the government and kind of blow the whistle, if you will. This is the first time in this country, 7 months after signing the Declaration of Independence, that the country looks at what it means to give and embolden whistleblowers. So they're nervous, right? They want to go to the government, but they realize that there are no legal protections for them. But the government realizes that they have an interest in individuals helping them uncover wrongdoing. And so what comes from this is, number one, the government pays for their legal fees because, of course, this Commodore brings claims against them for libel. So the government agrees to pay for their legal fees. The government also comes up with a very unique language that sets the tone for what is whistleblower laws today. And then in thinking about that historical stage, I want to go into some of the modern manifestations of what is now whistleblower protections. So we have, Bart's going to go into detail about the False Claims Act and the protections under the False Claims Act, but really that came about during the Civil War era, where contractors for the government were essentially selling faulty ammunition, food that was poisonous and causing the soldiers to get sick, things of that nature, and the government wanted to crack down. And you'll see this kind of throughout history. I'm not going to go through all of these modern manifestations of whistleblower protections, but that's one of them. The Sarbanes-Oxley Act, under Section 806, you have protections for whistleblowers that have reasonable belief that there might be wire fraud or bank fraud or violations of securities rules and regulations. And then going into the Affordable Care Act. So Congress was very intentional when enacting the Affordable Care Act to make sure that there were retaliation and whistleblower protections within this act, even so much as making sure that the retaliation claim was a standalone cause of action. So I'm going to throw it over to Kristen to talk about state claims.
Okay, since this is the Central Florida Healthcare Forum, I wanted to just address a couple of corresponding and similar statutes in Florida that deal with the Florida False Claims Act. And so we're an at-will state. What typically comes to me is when someone is terminated, they generally, always file some sort of retaliation claim for wrongful termination and say, but I told you that you did this, or you discriminated against me. And it's a challenge for all of us to deal with. So Florida typically corresponds with the federal, but I wanted to bring that to your attention. The next slide is specific to whistleblower laws. We do have two statutes. One is for public employees and one is for private employees. And the elements are listed there that an employee can bring a whistleblower claim private employees that if they reported that the employer violated a law, rule, or regulation. That is so broad. So just that falls under any sort of manifestation that can be concocted, or that is legitimate, or provided information to a government agency, or objected to or refused to participate in a policy or procedure which violates a law, rule, or regulation. So we've seen a lot of this come up in COVID in healthcare, because nurses will say, this person's not wearing a mask, or I'm not getting a vaccine mandate, especially in Florida with the special session and the legislation that you cannot mandate vaccinations. And then finally, the next slide, Florida does have its own False Claims Act whistleblower protection, but Bart's going to talk about the financial incentives of going under federal law. And so basically, it's not as attractive to lawyers. So Bart, let's
When
take
you
it
want me to talk
away.
about the False Claims Act?
Let's do it.
So I remember when I was doing my little self-introduction, I mentioned about being an assistant U.S. attorney prior to ever being U.S. attorney and prior to going into private practice initially. And the reason why I mention it's particularly appropriate right now when we're talking about the False Claims Act, because when I got there, I was really a young kid. I was just 2 years out of law school. And so they assigned all of these civil fraud cases to me. And the first thing, being a white collar criminal prosecutor, I started weeding them out. I said, well, some of these cases really are criminal. And so I would get with the FBI or whatever federal agency was appropriate to investigate the case, and we'd work up the case, we'd prosecute. But the lion's share of the cases really was civil fraud cases. There was no real teeth in the False Claims Act case back then, the False Claims Act statute back then. There was no incentive for an assistant U.S. attorney, particularly when you had a number, say dozens and dozens or even hundreds of small claims, the claims that for $2 or $3 each. You just didn't have enough in total damages to be able to justify spending the government's resources to bring in a False Claims Act case. So, to bring a fraud case. So we just didn't bring it. So then we fast forward and we see in 1986 gave teeth to the False Claims Act. And Ariel already told you about the beginning of the False Claims Act. So you go through under President Lincoln and you go through this long period of time where the False Claims Act really is dormant. It was not until 1986 when it just sprang up like a phoenix out of the ashes. And what happened was Congress decided to put teeth into the False Claims Act case, False Claims Act statute. And what they did, you see up there. But when I say really did, from the macro picture, you've got the individual changes up there they did. But from the macro, from the big picture, it gave teeth to law enforcement. It gave teeth to be able to go after and had some real bite in the statute to be able to penalize individuals and companies that submitted false claims. But the second thing it did, and I believe more importantly, it incentivized relators to file whistleblower actions. So fast forward, I told you about being an AUSA in those fraud cases. Fast forward, when I became U.S. attorney, I was assigned to the Attorney General's Advisory Committee. We'd meet with the Attorney General, we'd meet with agencies for 2 days, then meet with the Attorney General the third day and have lunch with him, talking about all the problems we learned and how we were addressing them on those first 2 days. And they were so concerned about the 86 amendments and the floodgate, they called it, that would be left wide open of all these whistleblower actions that would be filed. And I turned my head, I was on this they call it a KETAM subcommittee of the AGAC, which is a typical government name. But anyway, that's an aside. So I was on this committee and they started talking about, the sky's falling and we're going to have all these avalanche of cases. And I said to one of these other U.S. attorneys from Boston, I said to Wayne Butt, I said, Wayne, I think they're crazy. I just think they're chicken little, and that's not going to ever happen. Boy, was I ever wrong. The floodgates did come, and they just didn't come in as soon as everyone thought they would, because it took a while for them to percolate, these claims to percolate, and then to be discovered before people file cases. So really, beginning in about 1993, 94, 95 is when you started seeing, and then it really did. 95, 96, 97, the avalanche, the tidal wave really came through. And so you see in the 86 amendments, they lowered the burden of proof. They established liability for deliberate ignorance. And that's when I say they did away or they obliterated the ostrich defense. They increased the rewards for relators, and that's thus the incentive for whistleblower or related counsel. The other thing it did, I mentioned to you, there, you never would bring a false claim or fraud case for these little small claims, even if you had hundreds of them. But now all of a sudden, because it increased, it made individual penalties per individual claim. And initially, when the statute was first passed, it was a minimum penalty of $5,000 per claim, between $5,000 and $11,000 per claim. And now it's between 11, because it's an index to inflation, now it's between $11,000 and $23,000 per claim. Well, we tried and lost the Toomey case. If you don't want to try a False Claims Act case unless you know 100% you're going to win. And we tried the Toomey case. We didn't have any choice. The government wouldn't settle with us. And what turned out, what began as $30 million in damages, actual damages, ended up ballooning to $237 million, and the hospital had to sell itself to a suitor. I had no choice. A white knight came in and bought the hospital, and the local community hospital became one of a big, large chain of hospitals. So the final thing it did, too, and the most bitter pill, I think, for your client to swallow is after you've gone through all this lengthy investigation, all this angst, and the investigation is going 2 or 3 years. Some cases last, the Toomey case actually lasted 10 years because it went up to the Fourth Circuit twice. McLeod case, before I'd done that case, and that McLeod case lasted 6 years, and a tremendous amount of attorney's fees are spent in these cases. But the most difficult pill to swallow for the hospital and the management, the hospital, is they've got to pay the attorney's fees for the relators. So they know not only is the relator getting a cut of what they're paying the government, anywhere between 15 and upwards %, but they're also having to pay the damn attorney's fees. And that really, I'm not kidding you, I've had settlements get hung up because hospitals and providers and corporations did not want to pay the whistleblowers' attorney's fees. They end up swallowing that pill, but they sure as heck don't like it. So why is there such aggressive enforcement of healthcare? Why is that? Why is you've got all this money? They increased all these agents in 1986. They increased the number of agents. They increased the number of auditors, the number of prosecutors. They did the same thing with the ACA. They increased the number of agents. Additionally, auditors, prosecutors. And why do they do it? Because as Willie Sutton, the famous bank robber, said, when one of the reporters asked him as he was coming out of the courtroom, he was finally apprehended. And after 23 bank robberies, they said, Willie, why do you rob banks? He said, you're dope, because that's where the money is. And that's where the money is. The money is in healthcare. When we first began this, we've written 3 editions of this Healthcare Fraud and Collateral Consequences. When we wrote the first edition, and with not healthcare spending had not reached 10% of GNP back then. Now it's 19.7%, almost 20%, and it's not going down. It may level off, taper off a bit, but I suspect you're going to see as the population continues to age that we're going to be spending more and more. Hopefully we can cut it somewhat with telehealth, but right now the early returns are in. Telehealth is really costing us a hell of a lot more because it's so easy to commit fraud and just to get fast and loose with the rules in telehealth. So, and I've seen that from an enforcement standpoint. So let's see, you can sort of read the other ones. So it's difficult to separate the civil from the criminal cases now, because in every of these cases, what happened was U.S. attorneys' offices around the country in each district created task forces, and they use a holistic approach. So they have a criminal, the same agent that for OIG or the FBI that investigates a civil fraud case also is investigating at the same time, gathering the same information to see if that case should go criminal. And what DOJ did about 8 years ago, maybe 10 years ago now, is they started by policy making it mandatory for every U.S. attorney's office in the country to have a criminal AUSA assigned to every False Claims Act case filed, and to attend meetings and to monitor the case right along with the civil assistant U.S. attorney. So when we go into these meetings early on with the U.S. attorney's office, and I may bring an in-house counsel or maybe a COO that wasn't involved in any of the allegations, and we go in there and they say, well, who is that guy? He's an assistant U.S. attorney. What does he do? I say, well, he's a criminal assistant U.S. attorney. And they get all upset. But that's what you have now. And so it's a lot more likely now that a case that begins with the civil investigative demand ends up turning criminal, because you've got the same folks looking into it and you've got communication. It used to be in the old days, when I was an assistant U.S. attorney, they could not communicate with each other. It was forbidden by law, but that all gets relaxed later on. And you look at what we talk about a holistic approach. You've got civil investigative demands, you've got civil judgments, criminal prosecution, payment suspensions. If you're a large healthcare provider, even a small, if Medicare cuts off, if the government cuts off your payments, you can't stay in business very long if you have a very high percentage of Medicare payments. And then you have restitution and forfeiture. And finally, the most significant really is exclusion, which is the death penalty for any provider. If you get convicted of a healthcare crime, you're automatically excluded. For 5 years, you can be excluded for more. We're in a case right now where the OIG, and it's just under investigation, it's just a civil False Claims Act case, and the OIG counsel has said, oh, we want an exclusion for the two individuals of 10 years apiece, and for the company, 15-year exclusion. Well, they can't be, I mean, they can't be excluded for 1 year, much less 15 years. So how do you prevent, you know, in the Toomey case, they told me, I first got involved in the Toomey case, they said, we're not going to be like the McLeod case, because they spent over $10 million in attorney's fees, and we're not going to do that. I said, I just listened to them. I said, yeah. And so they ended up spending over $20 million, $23 million to be exact, in attorney's fees over a 10-year period. It's just, so how do you prevent that? You've got to somehow prevent it. And the way you prevent it is you have a robust compliance plan. Let's look at some practical tips. You implement that robust compliance plan. And when you implement a plan, it's great to have a little booklet with this nice compliance plan all written out, and you go up a page and you have your table of contents, but you have to follow the plan. Because if you don't follow the plan, it's worse to have the plan than not having a plan. You've got to follow your compliance plan.
And I'm going to stop you there.
Yep.
You're a wealth of knowledge, but I want to ask you, and I'm sure you have the answer. In thinking about, prompting an investigation and the questions that the DOJ maybe might ask, or the factors that they consider, how important is it to have an effective compliance plan to those factors?
The first thing they look at, whether it's OIG and Department of Justice and the U.S. Attorney's Office, that's the first thing to look at, is do you have a compliance plan? Gabe Imperato and I, my co-counsel, my partner, we're involved in a case right now where the clients really didn't have a compliance plan. Then the pandemic hit, the investigation started before the pandemic, and pandemic hits, they really have not really implemented. Now we're just, Gabe and his folks and Ann are implementing the compliance plan, and we've got to get compliance people in there that know compliance. We can't just have, you can't designate your COO as your quote compliance officer, because he or she may not know anything about compliance. You've got to have a legitimate, true blue compliance officer, and that's the first thing you look at it. And if you don't, the chances of criminal prosecution shoot way up. The chances are of exclusion go way up if you don't have a robust compliance plan.
If you don't have a plan, and if you, the follow through for sure.
And follow that plan. The other thing, you need to have compliance training. People talk about training, but you should have general compliance training for the sort of, it goes to everybody, but also job specific compliance plan. Because somebody in coding maybe needs to know some more specific, some more detailed compliance tips than someone that's in collections or billing.
When you have a compliance hotline and somebody makes a complaint and you can tell that they're disgruntled, or what do we do?
That's important, because most False Claims Act cases most whistleblower action cases in non-healthcare circumstances, in security circumstances, are filed by disgruntled whistleblowers. And remember when I told you that companies and management particularly hate that bill of pill about paying their attorney's fees? Well, that's why they hate it. Some of these employees have been longtime employees, and they've been irritants to management all along the way. And if you talk to Relators Council, they will tell you, and I've done some relators work, they will tell you that their clients are mostly peculiar, not mainstream kind of people that get under your skin and irritate people. They're abrasive people. And these are the kind of people. And so at the end of the day, you may have to pay their attorney's fees. So it is, but what you've got to do when you get that complaint in, and I always tell clients this, and usually I get them after the fact. These guys fortunately get them before the problem. But I can tell you what happens. You need to take that whistleblower, as much as they're an irritant to the company and to management, you need to first off acknowledge that you received the complaint and you're getting ready to look into that complaint. And then if it's taking a long time for whatever reason, because you may have to retrieve records or something, I would just periodically touch base and say, I want you to know we're still looking into that. It's taking us a while, but we're still looking into it. And then at the end of the day, if you decide it doesn't warrant any further action, or if you decide it does, you need to tell the person, you need to tell the whistleblower. But either we're not going to do anything, and here's why, or we've taken this action, we've reprimanded this employee, or we've implemented this change, or whatever the case may be. So that person feels vindicated. They feel like, you know, they gave me respect, and they realize I'm trying to do things for the betterment of the company.
But sometimes these whistleblowers, and I'm not disparaging them, but they are the disgruntled people. And so it's really important for me to, when it comes in from HR, that there's adequate documentation if we need to terminate them. So what happens when you know that there's a mole?
Well, that is the most delicate. We had that in the Toomey case. We didn't know we had it in the McLeod case. We knew it was a mole. In the Toomey case, we had a disgruntled physician, and he was always a problem physician. He was always up before the physicians committee for bad conduct and cursing to people and cussing out the employees and talking down to people and just treating people poorly. But they wanted to fire him terribly, and they couldn't. Their hands were tied because the False Claims Act case, the investigation at least, had already been known to the hospital. It is for real. That is the biggest problem of all. But most of these people, if you talk to Relators Council, are disgruntled employees, and you have to determine how you deal with it. And that's when I always look back at these guys and say, that's your problem, not mine. So what if you have an investigation, you find out that there's something that really is a problem, and you need to get to the bottom of it. And so you probably do an initial dive by using one of your employees. It can be the COO, or it can be an in-house counsel. But let me say this, it's much better practice to at least consult initially with outside counsel. And really, if you think there's a real problem, if that's what you're discovering, what it looks like there's a real problem, a deep problem, even a systemic problem, you need to have outside counsel conduct the investigation. And the reason why is you want to protect the privileges. And you also want to help your employees, because your employees may not be as skilled in the kind of internal investigations. And on top of that, if you go to the U.S. Attorney's Office to self-report something, it's much greater credibility if it's coming from outside counsel rather than the provider's employee or the provider's in-house counsel. They take those kind of results of an in-house investigation, the government does, with a grain of salt.
I would also urge you all, when thinking about trying to get these matters, don't be shy and don't shy away from the fact that you don't have an established relationship with that company. Because a lot of times, often more than not, the company is assessing, whether they want to retain a law firm that they've worked with for a while and they have a relationship with, or a true independent outside counsel who might look better, might get more deference. So you don't be shy about the fact that you don't have an established relationship, especially if there's an RFP out, make sure that you're trying to get that business.
When you're in an in-house counsel, what sort of resources are available to you? Do you have discretion do you participate in the investigation? How does that work?
Well, I'll say every company is different. Culture is very important, but for our company, I certainly am at the table. I have the resources, but I personally have been emboldened with the power to reach out to outside counsel, and I make sure that I do it because I want to make sure that I'm protecting our company, and we truly, at the end of the day, are looked at as being independent in these situations.
So going back to something Kristen said about the whistleblowers, a lot of times these whistleblowers, they hire a relator's counsel and they file a complaint, and it turns out the government begins their investigation. This has happened many times in cases I've handled, that the government investigates all these claims, all these allegations that have been alleged in this complaint, and maybe Nelson Mullins gets hired to represent the provider, and we sort of disprove each and every allegation. Well, you think, oh, that's the end of the day, that's the end of the case, right? We've disproved everything. But the government, we used to have an expression that once the camel gets his nose under the tent, they look all around. The camel doesn't just look in what it came for, it looks all around. So generally, in many cases, if not most cases, when the government starts looking at a healthcare provider or really any company that deals and submits claims, they find some kind of violation. Okay, it's like the IRS auditing an individual taxpayer. They're going to find something. Well, many times they find larger problems. And in this case, I'm in a case right now where the whistleblower, each and every allegation was disproved. So what the government did is they set aside the whistleblower's complaint and they filed their own complaint. They filed their own complaint with a whole new, not a single allegation that was in the whistleblower's complaint is in the government's current complaint. And so that's sort of what you have to deal with.
That's your worst nightmare, when the scope just broadens to something you never thought about.
So what happens when you know there's been a False Claims Act case filed, and so you start dealing with the authorities, with the U.S. Attorney's Office, Department of Justice, or normally you wouldn't deal so much with the agents. I do because, once you do this all the time, you do deal with agents some, but mostly you deal with the assistant U.S. attorneys. And I think the most important thing is, don't start throwing hand grenades and bombs when you first get in the case. You want to try to work towards some sort of resolution where you can narrow the issues. And what we do at the same time they're doing their investigation, we're hurrying and doing an internal investigation. If that one has not already been done, we're doing one, and we're trying to determine the nature and scope of the problem, the depth of the problem. Is the problem systemic? I mean, if you're a large scale provider and you have different offices, I mean, is it limited to one office? Is it limited to one department? Or if it's a hospital system, is it all of your hospitals? Is it systemic? Because that's when you have the biggest problems, obviously. So you want to be able to have an open relationship, an open door policy with the assistant U.S. attorney or DOJ fraud section. You want to have a lawyer that can go in and it's going to be respected because they know they can trust them. And what I always say to the assistant U.S. attorney or whoever's investigating the case, I want to say, look, we're going to cooperate with your investigation. We're going to get to the bottom of it. If we find that we've received an overpayment, we're going to tell you about it. And let's take issue as we go along. I want to have an open communication. I'll meet with you. And so that periodically I'll touch base with them and face to face. Even in the pandemic, I tried to meet with them in person when they could. We would usually meet at Nelson Mullins' office because they couldn't go in their own offices, but we would try to meet face to face. And just to get a temperature for where to go, what new allegation has popped up, because they always do. Once the agent gets there, someone else says something, and it leads to someone over here, and someone over here says something. And so then you're dealing with new issues all the time, and you want to try to put to rest issues as they arise, so that at the end of the day, you can narrow the issues. And by that open communication, you narrow the issues where you and the defense lawyer and the assistant U.S. attorney agree, okay, we started off with 15 issues, 15 allegations, and now we're down really to 2, and the 2 aren't nearly as bad. How can we get this resolved? I mean, you're going to go, or you're going to go over trial over 2 allegations, or you're going to try to work them out. You look and see what the damages would be. And you try to work them out because you don't want to go to trial in one of these cases. I can tell you, I've tried 2 of them, and you just don't want. Mike Bittman has tried these cases. Mike Bittman's the only lawyer I know that's won one of these cases, because the government usually wins. Even if they win a few claims, you might as well win them all. I mean, it's just a tough thing with the penalties.
So when this comes in and we start our investigation, we usually parachute into a situation. But we do a concurrent employment investigation, and then you do what it is that you do with respect to the False Claims Act. So just like you said, the relationship with the U.S. attorney is important. The relationship among us, and then, as in-house counsel, that relationship is so important. And it becomes your whole life.
It becomes your whole life.
Yeah.
Yeah, cases last a long time, and you go through a lot together going through the cases.
And I think that's why you guys are so important, because, we're in the business of keeping our business going. But, you having those relationships and being able to steer the investigation and really help us narrow the gap in the scope.
Yeah, and one of the things you do in these investigations, and you try to do it as soon as you can, you sort of do initial interviews with employees, but at the same time you're doing those interviews, you do upjohn warnings and all that, where you tell them you don't represent that individual, you represent the company, the privilege belongs to the company, and you make sure that's real. And I still use a little written script. So if it ever comes up later on, I can say, nope, here's my script. I use it every time. Check, 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 check. So, but it's really important to prep them at the same time. And then if you discover someone you think's got really valuable information, the agent sooner or later will come knocking on the door at 5:30 in the evening, 6 o'clock, 6:30, right at supper time. It's usually either the husband or the wife answers the door, and whoever the employee is, they go out, they want to go outside, and the agent wants to talk to them right then. And I always tell, when I first meet with the witnesses, I say, look, you're welcome to talk to the government if that's you decide to do. It's not my decision or the company's decision whether you talk to the government. Okay? You can talk to the government. You've got a right to talk to them. You've got a right to not talk to them. But let me ask you this: if you would do this for us, if you would just let us know if the government contacts you, and tell them, look, if you want to talk to them, here's what I would advise to say to them. You don't have to say this. You can talk to them right then if you want. But what would be helpful to us is if you would tell them, I am glad to talk to you. I'd like to have the company counsel present, or I'm glad to talk to you. I'll have someone call you, or I'll call you tomorrow, or I'll call you next week. But don't let them hotbox you and call you and talk to you right then. Again, if you want to talk to them right then, that's your right. I'm just telling you, what you have available is you would be able to have me or someone like me prepare you to talk to them, and you'd also have the right to have one of us sit as counsel with you. And we would be representing the company. You could have your own counsel there. But I always say, you know why you ought to have counsel there? Because every time there's a government agent interview you, you know how many people they have in the room? Two agents. One agent asking questions, the other agent taking notes. You know how many there are of you? One. And if there's a dispute later on, who do you think is going to win that dispute? And sometimes they don't mean to write it down wrong, but they've got their theory of the case, they've got their idea of the case, and that's sort of how they interpret what you say. So it's real important to prep those witnesses from the very outset, and then come back, and the key ones you can determine, once you understand the nature and the scope of the problem and the extent of the problem, you come back and you prep in more detail. And let me tell you something. That has won so many cases for us, because I represented a hospital that was under criminal investigation, and we prepped every one of the doctors, and there was a lot of doctors. We prepped every one. We got a lawyer for the doctors, just we call them a witness counsel. They represented all the doctors, because the doctors were just witnesses, and we prepped those before any agent ever reached them. And by the time the agent reached them, well, particularly, we got to sit with them. So we after the agent questioned the first one, we went back and prepped Doctor 2, 3, 4, all the way to Doctor 13.
And you're
Once in-
also, I was going to say, you're also gathering
You're
information.
gathering information. That's
And you're
exact-
kind of informing them.
informing, that's right.
But
as we go.
once they're involved in this investigation process, we kind of need them at that point. So from an employment law standpoint, number one, they're protected because they're participating
Yeah.
in an investigation, and we can't fire them if they say something that they believe is true. So you're kind of married to them at that point.
You're stuck with them. That's the hardest thing to tell clients who want to get rid of them is you just sort of.
Even the worst
yeah.
human, you still have to, yeah. Sad but true.
Yeah.
True.
So I think we're going to go to the let's see,
Best
best
practices.
practices. So when we were thinking about all this and we've been talking, one tip that I have recognized over the past couple of years is throughout, going back to the initial slide of the challenges that you have all been going through, is that HR and compliance departments continually are saying, that's not my job, that's your job. And so any organization that gets involved in any sort of compliance issue, False Claims Act or whistleblower or retaliation, anything that has to do with a compliance issue is really an HR issue as well. And I've literally been involved with clients that HR is calling me, and on the other, on the other phone, compliance is calling me, complaining about the other. And what we really need to do is focus and have a holistic approach in your organization, and don't have these people run around. So if you're compliance and your HR, get to know each other and work with each other. Because especially during COVID with these OSHA, ETS for safety with COVID, and just the monumental hurdles that you've been through, compliance is exhausted, HR is exhausted. We can't find nurses or doctors. So, find a way to get the two together, or have a liaison between the two departments. Or, you're going to have to hire counsel to babysit the situation, which is sometimes the only way you could get the two to see eye to eye. So do you have something?
Yeah, I would say really just being consistent in setting the tone. We talked a little bit earlier about following up with the whistleblower, and that really is to instill confidence that the processes and the policies that you have in place that you're following, and that they really can adhere to them, and something might come from it. So same thing with this, consistency in management and tone. So it comes from the top. CEOs of companies have to really embody, that they keep their core codes of conduct, and the core values, they keep them at heart, and that they really believe in them. And that includes a compliance plan that they really believe that, it's important to have it. So it starts at the top so that there's buy-in from all employees.
And just building on what Ariel said there, go back to how you treat that potential whistleblower. When they make that complaint to the hotline, or they make a complaint to whomever they make that complaint to, and you want them to know you take it seriously, it's hard for management. Remember, if that person has been a troublemaker and an irritant in the company, it's hard to acknowledge that they're really providing you anything of value. The first thing you want to do is just be dismissive about it. And management really does have a pill to swallow in the early stages too. But that very thing, they don't want to give any credibility or any credence to what this person, because this person's always complaining about something. And so, they've got to, because these cases, the old nip it in the bud, like Barney used to say on Andy Griffith, right? Nip it in the bud.
And they may always complain about something, but you would hate for that one complaint to really turn into something.
Does anybody have any questions? Or you want to take the break? The snacks look really good.
Okay. My name is Mike Siegel, and I am a partner at Nelson Mullins, and I'm the head of the value-based the value-based care division of our firm, which we only recently began. And we're very fortunate today to have a very good panel, which includes, first of all, Melissa Mora. And hold on 1 second so I can be looking at her. Oh, here you go. Melissa Mora, who is, as you can see in your program, the Divisional Chief Legal Officer of Managed Population Risk Division at Advent Health, which is a very significant hospital company in Central Florida and actually all around the country. And then we also have Robert Ball, who is Chief Legal Officer of Enlace Health. And in a few minutes, he'll tell you what his company does. And I think you'll find it very interesting. And finally, we have my partner, Ed White, who works heavily in the value-based care space with me and has created quite a few. He's written a very, very good article that if you haven't seen it, you ought to look to find it in 2021 about the value-based care changes in Stark and anti-kickback, and has also written some other things and has created some very good charts that he's going to share with you today. So with that in mind, I'm going to start by asking a question to Melissa. Melissa, CMS has stated in writing that all Medicare fee-for-service beneficiaries will be in a care relationship with accountability for quality and total cost of care by 2030, which, if we can count, is only 8 years away. This is value-based care. Most hospital systems, especially large systems like Advent Health, have profited greatly under fee-for-service and are reluctant, generally, to move towards a new system that works hard to reduce profitable hospital services. How and when do you expect systems like yours to move to value-based care?
So I think many of us can say we've seen this as a journey, and it started many years ago with the upcoming of ACOs, and actually you could go back to the HMO days and say that really you started this journey back then and trying to figure out what worked. And one of the things lacking at that time was really the data integration. And I'd like to say we've come a long way with data integration, which we have, but there's still so many disconnected pieces. And so our system over the last probably 5 to 6 years has spent a number of resources, putting together infrastructures to support this move towards value-based care. And so we've started with shared savings programs, looking at bundles, working through BPCIA, CJR, and the like. We've recently started Well 65 Plus practices, which are dedicated to the direct contracting entities. And then we have primary care first practices, which is also under the CMMI models. And so as we move forward, we've been looking at and working with payers under the CMMI programs and then other governmental and commercial plans to move in that world towards value-based care. So I think it has been a struggle at different points in times, especially when you're dealing with a primarily fee-for-service institute that generates much of its revenue through fee-for-service. And so it's getting everyone aligned. And so our president has really taken an interest and put at the top of his priorities, manage risk, making sure that we're moving in that direction, seeing what CMMI had published with regards to the GEO model, which ultimately did just get canned as part of the move from DCE to ACO REACH. But all of that started giving more light into where we think the government's going. There's not enough money to care for patients. And so they have to find a way to give money still so patients can get the care they need, but also limit that for all of our systems. And so especially right now, as volumes are down across the system in hospitals, it's really highlighting the need to start this trajectory of change. And so we've been working really hard in putting together plans, putting more emphasis on our population health services organization, who does focus on how do we integrate these risk payment models into our systems? How do we work best with payers? And then how do we work with our providers? Because that's ultimately the key in all of this, is making sure the providers are on board and how we're moving forward. And so we've started different initiatives, planning groups and the like, to ensure they're part of the conversation and not just being told, we think we need to do this or we think you need to do that. It's more of a how do we do this together and keep moving forward to meet these demands as time goes on, to meet the 2030 deadline.
Thank you very much. I should have probably asked Ed to talk first because I didn't get him to say the specific thing. So Ed, can
To the microphone. Okay. Yeah, I can't hear you.
Sorry, this is why I should have mic'd up. Okay, first of all, Melissa, thanks. That was very interesting, and it's going to be a big challenge. I should have asked Ed first to talk about the question that I have for him because it's a lead-in. And so, Ed, can you spend a few minutes and just tell us what is value-based care?
Sure, and I'm gonna slide over here where I can get on the PowerPoint. I don't
Sure.
But a couple of things. Basically, there's some new regulations that CMS, which is the agency that administers the Stark Law, and the OIG, which administers or enforces violations of the kickback statute. And they got together, and for the first time, really in a significant way, they coordinated to build a set of parallel rules to allow parties to transition towards value-based care. And that's basically towards risk-based contracting. And it's the first time they've ever done it. And for those of you that are in the space where you have to deal with Medicare and the restrictions that come with that, it's been very difficult to move towards value-based contracting. So these new rules are designed to accelerate that. And as Robert talks in a little bit, he'll be talking as well from the commercial side, but it's really a time where now the federal government's pushing providers, and like Mike said, they want to be there by 2030, have everything Medicare and some fee-for-service model, and risk-based model. And so they've reoriented the laws to help folks get there, and now commercial payers and the federal payers can now both be pursuing this objective of doing risk-based contracting. If I may, I'm going to just slip, I apologize, over here and just get the PowerPoint going here. And try to give, does somebody have my clicker for the projector? Is there a device to click the PowerPoint? This is a depiction, basically, of what we sort of view as a sort of a chart that gathers everything that with the value-based enterprise. And so, under these new rules, the value-based enterprise is the centerpiece. Do you have a clicker here, please? It's not on the podium. They don't have the clicker.
Well,
What's he changing with?
Let me just tell you that CMS, when they created the accountable care.
What?
Let me just tell you while we're waiting for Ed, CMS, when it created the accountable care organizations under the MSSP accountable care organizations in 2011, said they were focused on the triple aim. And the triple aim really is value-based care. And the triple aim is providing better quality services, or at least maintaining what you have, for a lower cost for a defined population of people. And although under the ACO REACH program, they've kind of defined the population of people to basically say equitable, serving underserved areas, it's essentially the same thing. So it really is the concept of providing better services for less cost for a defined population of people.
Can you change it back there? Okay, let me have control.
And I'll just continue.
Okay.
So when we saw the new regulations come out in the end of Ed, you ready? Oh, he's not ready yet. When we saw the regulations come in at the end of 2020, we were really, really excited, frankly, about the changes that we saw to the Stark Law and to the anti-kickback law, which essentially allows
with ownership exceptions and safe harbors. And basically, the value-based enterprise is a hub that you plug into these new rules. And to have the benefit of these new SARC exceptions and these new safe harbors, you have to create a value-based enterprise. And I like to refer to the value-based enterprise as the party's own innovation center, because there's really no rules. You get to make up your own protocols, your own processes, and you have to be working towards the value-based purposes to have these protections apply. And eventually, the value-based enterprise can migrate to being a risk-bearing organization. And that's what the government is really trying to motivate you to do. In these rules, and I mentioned earlier that the two agencies work together in tandem, which is very unusual. And I refer to these, the nomenclature is a little bit different in the regulations, but it's three different models that parties can work towards. There's a care coordination model. It's designed to let the providers start, coming together to work on value-based models. There's a partial risk model, and there's a full risk model. And these are really designed to allow the parties to migrate from wherever they are. And you have some providers today that are very sophisticated. They're already in risk-based contracting, and you got others that haven't even begun to start. And so this is sort of an evolutionary path that any providers can go into. The value-based enterprise primarily has oversight for, you have to be working on at least one value-based purpose. And each of the parties has to be part of that value-based enterprise. And the classic way to do that is just plug in through participation agreements, much like an accountable care organization has providers plugging in through the participation agreements. But you have to have a governing body that's responsible for the oversight and make sure that the participants are actually moving towards the goals. And the rationale for that is you have new exceptions from the Stark prohibition, which is, it prohibits referrals by physicians to entities that are providing designated health services. And then the anti-kickback statute that prevents any sort of remuneration for referrals. So you're getting these new exceptions to create these new relationships in ways that may otherwise violate these rules. Mentioned earlier, the value-based arrangement is really a participation agreement. A value-based activity, basically it's the activities you're doing, but the Stark law and the care coordination model allows a referral to be a protected activity, which is a nice feature to have. The value-based purposes are basically four: coordinating care, bringing providers together, working on common protocols of reducing costs and increasing quality, and transition from fee-for-service to value-based arrangement. So you have the classic sort of accountable care organization objectives of lowering cost, increasing quality, care coordination. But here you also have helping the parties transition towards risk-based contracting. And I'm gonna kind of move through this quickly. Target patient population, you get to define that completely. You have to do it in writing. So you get, as providers, to choose the population you're gonna be working on, which is different from the accountable care organization that Medicare has today. The care coordination model, I'm not going to go completely by the slides, but a couple of points I did want to make. Some of the significant distinctions, and if y'all are familiar with Stark and anti-kickback, once you get, all the Stark rules have a fair market value requirement. Some of the compliance folks can, if you sat in some of the earlier sessions, you may have heard some talk about compliance issues, and there's a lot of cases that have evolved. Either the parties they didn't have fair market value in their relationships with referring physicians, or they violated this standard in Stark that says you can't have compensation that varies with the volume or value of referrals of designated health services, which is the Medicare business, or even other commercial business. Those rules are gone when you get into risk-based contracting. So what we tell folks is you can reduce your compliance risk and the costs that are associated with that as you evolve down this corridor of risk-based contracting with a value-based enterprise. The other feature I wanted to highlight, you can also, I'm going to go back to the charts now, but you can really have an arrangement, and what we are working with some folks and showing folks how you can move from the simplest model of care coordination to a sophisticated model of creating your own risk-bearing organization. And again, the Medicare program wants to be here in some shape or form by 2030 for all their payments. And so, and this is what we refer to as a provider-driven model, sort of the evolution of a risk-bearing organization. And, you know, it could be a facility of any type. It could be, you know, micro hospital, surgery center, large physician practice, whomever wants to be sort of the entrepreneur to set up the value-based enterprise. A value-based enterprise can be as simple as contractual relationships, but if you can do anything meaningful, it should be a separate limited liability company, much like a clinical integration network or an ACO, and those could even overlap. And then you have to develop a relationship or rapport with providers that will work on some sort of value-based activities and purposes. And so in the step one, we're showing, and we're actually working on some projects now where we have a facility that it could be a micro hospital. You have a facility that wants to create a value-based network with the providers that are using that facility. And classically, things that hospitals have done, like care coordination programs, gain sharing, co-management, clinical integration, all that stuff can fit within a value-based enterprise. And in this step two, what we're showing is basically the care coordination model where you're bringing together the providers under a common platform, common software, the systems, protocols, and they're going to now start working towards, you can call them customized protocols. You get to create and invent this stuff as you go along. And in this model, we've got the facility basically funding the value-based enterprise. And that's just to highlight an important point. The value-based enterprise can disproportionately fund the infrastructure to stand up the value-based enterprise. I mean, one or more of the parties can do that. And that's ACOs have that ability through their early waivers. But here, it allows you to capitalize and fund the startup costs. Now, when you're in the care coordination model, for start, the fair market value standard and the prohibition against compensation varying with the volume of value referrals goes away. Got to run out of time?
I'm going to get on to another, you're going to have another chance.
Okay. Sorry, didn't mean to disrupt. This was a technical. But anyway, we can evolve to the third step through these rules. But go ahead, Mike.
Thanks, Ed. I know you could talk about this all day, and I'd like to hear it, but then you're going to have another chance to talk some more. But I want to get to our other speakers too, because I'm sitting next to Robert Ball. And Robert, as you know, how to handle and how to deal with value-based care means different things to different people. And I would like you to talk a little about your company, Enlace, and tell us where you fit in the value-based care equation.
Absolutely. And thanks for having us here and having me here, and great to be able to talk to you all. So Enlace has actually been around for about 10 years. It came out of the analytics space. It was called Aber Informatics out of Columbus, Ohio. So we rebranded it as Enlace Health. But so sort of growing out of the analytics space and seeing a lot of what Ed and everyone's talking about everybody is in this evolution at a different place along the way. And part of what you have to face is whether you're being pushed because you got mandates from CMS to do something by 2030, or where we live most of our life, we can work in that space too, but most of where we are is in the commercial space and just trying to get the triple aim and trying to get some savings out there and make things much more efficient is where we grew out of. So what we built is really an end-to-end solution that has a platform as well as services. So starting with opportunity analysis and looking at how to analyze what you can do to set up a value-based care program, and then building bundles, building episodes of care, and pricing those using something like BPCIA or Prometheus, different models to do that. And then we have a team that'll actually help and go out and build and negotiate the network contracts and build the provider networks, because we work with payers, providers, providers, anybody across the value stream. And then finally, kind of back to another point Ed brought, is we've built a purpose-built platform, a system, a SaaS system that will do the claims administration. So most every claims administration system out there is fee-for-service based. There's not a system of record. So we have this very open platform that you can come into to be that common platform that whether you're a payer or a provider or a downstream provider or another technology partner, we can integrate and then manage the whole system. Because I've spent my life not as much, not so much in healthcare, but around where technology kind of meets law and then growth. And I've seen some wonderful technical ideas, the wave of a new technology sort of hit the beach of workflow, and how do you manage the workflow? And it's a great idea, but how do I actually make it happen? So we've built this single ecosystem for payers, providers, technology partners, and for the benefit of patients or large employer plans. And the platform will support all sorts of value-based care models, from retrospective, prospective, partial risk, full risk. We can even kind of manage if somebody in the downstream needs to be paid on a fee-for-service basis, we can handle that. Shared savings, capitation, most any of these different ways that you might come at it, again, because everybody comes at this at a different point in their evolution and a different focus of what they're doing. Right now, our focus is primarily on specialty care, so orthopedic, cardiac, maternity, things that lend themselves to bundling, lend themselves to a defined episode of care that can be scoped, priced, and managed end to end. So we've been, like I said, we've been around about 10 years, and we've analyzed over 300 billion in claims. We're in 94 markets with about 31 million lives covered. So we're up and running. And fortunately, one of the reasons I joined is we just raised a round of capital, about $60 million to fund the growth. So very excited to be here and be part of this movement in VBC. So.
Thank you very much, Robert. Very interesting. And now I'm going to go back to Melissa. Melissa, my experience as a lawyer has been that most hospital employed physicians have employment agreements to compensate, at least in part, based upon the employee billing for a certain amount of resource value units or RVUs. And I'm sure that Advent Health and their employment contracts are no different. This incentivizes the physician to provide more services, but it doesn't push them to focus on value-based care. Many of these agreements are long-term. How do you intend to resolve the dilemma of the employed physicians not being incentivized to provide value-based care?
So it's interesting, and it's a dilemma we're facing, and that I talk about quite often at Advent Health as we're moving towards this value-based world. Speaking about what Robert does, we're working through commercial bundles and what that looks like. And in our first bundle is going to be on a maternity bundle. And one of the things we're working on is the way in which our employed OBs bill and collect and drop claims today, and trying to actually ascertain who does what, because we use laborist groups in some of our facilities. And so it's connecting all the dots to the right pieces to make sure when we bundle the payment, and making sure that the doctors, their fear and hesitancy that they share about value-based and what does it mean. I think Ed and Mike might share, clients are hesitant to start using these new waivers, safe harbors, and exceptions, because there's still a lot of unknown out there. There's a lot of, we don't know what we don't know, and we don't know where we're going. And so our doctors feel the same. And so we've really just been talking with them, floating with them about different concepts and ideas. We took upon a case study over the last 6 months where we did a risk-ready review of all of our practices to see where they sit. Are they ready? Are they ready to move towards risk-based compensation in their practices? But then what does that mean for them? And so it's trying to find what is the common ground. How do we do this slowly? So, we're looking at models where they'll still receive a base compensation, but the incentive might be more tied to a risk quality incentive type compensation versus it being completely tied to worked RVUs as it is today. We're looking at models under the Primary Care First program that will help them share in the risk tied to our performance overall as a practice, and what CMS attributes back to our practices if we're successful. And so we're trying to tie them in and slow move it so that there's not this fear where they want to exit, because there's a lot of promises out there from other groups that we compete with. Some of them have really come to the forefront when dealing with value-based care. One of our largest competitors from a group perspective has really found the sweet spot of managing Medicare Advantage lives and the like. And so you hear a lot of feedback from our employed physicians when we talk to them, or they've been talked to, well, why aren't we getting that? And so over the last year, we've been working with them to share in some of the clinically integrated network gains that we've gotten from payers, giving back to them to show that there is money out there that can be earned. But there is that trade-off that they initially have to take the step forward with us, and that hopefully it will come back in the end. And we're working with them to understand the infrastructure we're putting behind them to help them be successful, which I think is the key, and making them understand the importance of using the right specialists, using the right mode of care, why it's important not to overuse, to make sure their patients are getting to the right place that they need care from, and not to a higher level of care when not needed. So we're really trying to support them from a system-wise, but also settle their fears about maybe not having a set-based compensation, but what this could look like as we evolve.
Good luck.
Yes.
One more question for Robert, and then I'll get back to Ed. Robert, as we've been talking about today, there's a lot of push for risk-based entities and taking on risk and value-based care.
Yep.
I want to know, what are your thoughts about that in what you do, and how does your company figure into partial and full risk contracting?
Well, currently, most all of ours is really working with a lot of payers who are still maintaining most of the risk. So we have some shared savings, and we have some experience with hospital units that have done some great savings, multi-million-dollar savings in the maternity space. And we've shared some of that savings. We're looking to do more of either partial or eventually full risk. And a lot of my experience is in the payment space. So when I look at that, it's really managing that risk and figuring out where it needs to go and how to manage it best. But I think we see a huge opportunity in the full risk area for a lot of growth and a lot of building around really good bundles and really good episodes of care that can be managed. And to your point, it's for the betterment of the patient outcomes and to save money. And there's just there's so much, as Captain Obvious here, so much inefficiencies out there. If you get a way to do that, where you can start to pull out these inefficiencies and look at the data to see where those inefficiencies can be addressed and be freed up from sort of having to then put it all back into a fee-for-service type mentality, we see a lot of opportunity there. And quite frankly, there's a lot of financing money out there that wants to get behind that. So.
Ed, I'm giving you up to 15 minutes. So,
I don't know if I need 15 minutes, but did you have a question, or you want me to just?
You got to have a question. So here's your question. You're constantly talking and writing about value-based enterprises and their expanded role in healthcare with the advent of the new Stark and anti-kickback law. Can you give us a short explanation, as you already started, about value-based? Just continue what you were doing and talk a little bit about how this can really be used to increase opportunities for healthcare businesses. A lot of people out here in healthcare business, I'm sure they'd like to know.
Sure. So back to this slide and sort of a couple of the points. And I know, Melissa, the unknown, sometimes people there's a lot of trepidation with what you don't know. But I think that the reality is, if you look on the far right, where we've got basically the value-based enterprise has evolved into a risk-bearing organization. And the thought is, you get everybody working on in step 2 on, you get basically the care coordination, all the providers functioning together. And rather than just waiting on a provider to come or payer to come to you to participate, this is turn it the other way and give the providers ability to create their own value proposition and go to the payers. And that's what the far right, the step 3 is once they're functioning together, then really you have the ability, unlike in the past with all the complexities of Stark and kickback, to really start approaching a multitude of payers. It can be the commercial payers, it can be the self-funded plans, It can be the Medicare ACOs, Medicare Advantage, Medicaid MCO, but you're bringing a value proposition. And the idea is if the providers are creating this first and approaching the payers, you may have different results. And if you just wait for payers to come to you with their value proposition, this is what we want you to do. And so, to the extent of a facility of some type and the groups that work with it can create their unique value propositions, and you have a clean, just a blank slate to innovate and do whatever you can think of. We call it customizing protocols. I think one of the things that that Robert highlighted is you got to have an analytics platform and sophistication to carve out. And one of the things Robert and I were talking about last night was that, you may have, just like ACOs today and some of the commercial contracts, you may have some providers participating on fee for service, some doing on partial risk, some doing on full risk. You need sophisticated analytics to be able to spread that money around, figure out how to pay and what to pay. And that's, so, people like Robert help with that. And then the other thing is we're talking to providers and bring them together in step two. You really need somebody, as lawyers, we can help describe the law and draft contracts and weigh risk and assess that sort of stuff. But you also need people that can help get in there with the clinicians and create the protocols and create the processes and help steer. And I call that, operationalizing the value-based enterprise. But there's ways, and really this is an invitation for everybody to get involved. I mean, just not the big players. It can be any providers can start combining along these pathways. And what we have is we talk to different people, and I'll go back to the first chart. I mean, there's sort of endless opportunities here. And when we talk about things like there's no fair market value standard and there's no volume or value prohibition on compensation. When you look at this, I mean, we're just sort of putting a lot of different scenarios from a lot of different questions, a lot of different providers we've been talking to, but everything from the value-based enterprise down would be compensation relationships that would be protected from these new rules. And, we hear folks, and particularly 501c3 hospitals, they say, well, we still have the private enrollment, prohibition. We still have to deal with fair market value from a 501c3 perspective. And the takeaway point here, just because you don't have a fair market value standard doesn't mean you don't pay fair market value. It's just you take away the compliance risk. So you're radically changing the game when you minimize those risks. And so, we've been talking to a lot of different providers of different types, but you can have, if in the top box, I've got a multitude of providers. It might be the party that's basically the momentum to create the value-based enterprise. If there's equity participation in a classic provider, they've got to use the classic Stark and anti-kickback rules to protect those investments if referring physicians are there. But you can have investors in the value-based enterprise, and that's not an entity providing designated health services. You still have to be mindful of the anti-kickback statute, but there's a lot of variations. I mean, we're getting questions about how can primary care participate? Well, anything you can create in a continuum of care, and I mean, this is, the invitation for the folks that are in ACOs, which are largely primary care driven. In that continuum of care, there could be a place, for them to help manage care coordination at some level that results in a greater outcome. You can have under Stark, the specialist or primary care vice versa, one contracting with the other. And Stark will protect the relationships between the providers as long as they're plugged into the value-based enterprise. ACOs and MSOs and IPAs, I mean, you can just gather networks. The ACOs might be the network. They might be the driver for this. But at the end of the day, it's the world is changing, and Medicare, being one of the big payers in the marketplace, is pushing people towards this. And while there is unknown and there are risks, I think there's new opportunities here. That's the other side of the coin to push through these new rules. And and innovation is the the name of the game. And some of the folks we're talking to is, when I say new opportunities to align providers, but we're also seeing entrepreneurial type folks viewing the value-based enterprise as its own ability to create profits and returns. And we're doing work with a direct contracting entity and some ACOs, and we're seeing how they're allocating and negotiating with providers. And And this is all downstream risk. I mean, the providers themselves are sharing risk at certain levels. And, you know, and intuitively, there ought to be greater returns if you're taking part of that risk. And there ought to be, when you say, you know, how can you get the physicians interested? Well, if you can show them they can make more money, perhaps by assuming responsibility, you know, starting with a continuum of care coordination to, you know, following protocols, et cetera. I mean, the end game is all about, you know, entrepreneurs making money. And so, you know, we think there's opportunities in the risk-bearing organization itself, apart from just owning the facilities and regulating who refers to it, et cetera.
It only took 5 minutes. That's pretty good. Now I got to figure out what to do with the rest of the time. Okay. And again, I forgot to put the thing on, but I hope most everybody heard me. Okay. I was just saying that was shorter than I thought, but I want to throw in something just to add to it. And I'll have all three of you talk about this before I ask the other questions. Getting back to the goal of 2030 that CMS says, and you know, their goals change and sometimes they say it and then they back off. We've seen that enough times. But let's assume for right now that they're serious. I'm seeing more and more that some people are very aggressive about this, but others are like, well, I'll wait around, I'll see what happens. Like the question we first mentioned. And that's a common thing. And I just am wondering from all of you, how serious are you seeing people in getting to really moving towards at least partial risk? We know that you don't just wake up one day and say, I'm going to take full risk. You'll be broke very quickly. But how much do you see people really pushing to do this? Even big companies like yours, Melissa. You have people like you who work there and are very professional and know a lot, but you also have to report to other people and ultimately to the board. And some of the board people may not know a whole lot about this stuff. So, and that happens with every company. So I am just wondering how much is talk and how much are people actually doing it?
So I think for Advent Health, as I mentioned, our president has this as one of his priorities. And so it's a board priority. It's on our strategic initiatives. And so it's a very important topic that's being addressed, being talked about. More resources are being put into our population health team. Our new division was created last year, which is when I switched positions and moved into a divisional role because of the focus on this and because we know we need to grow and move in this direction. I think there's a lot of companies moving in this direction, not just Advent Health, but other health systems throughout, others that have been very focused on it for a number of years, even prior. And then you have the opposite side of this, where you do have those entrepreneurial organizations moving into the space where you saw with direct contracting entities. There was a number of private equity groups that came into the space, which is now why I think they're transitioning to ACO REACH, and they're really trying to identify who wants to be in the space, who needs to be in the space, are people in the space for the right reason. And so CMMI is putting a lot more emphasis on provider-driven type ACO REACH practices and organizations, and looking more at the who is behind the walls or the face of these private equity groups, because they want to make sure it's being used correctly. So just like Medicare Advantage, when it first came online, you had companies come in who were making a lot of money, but there wasn't a lot of accountability. And now we're moving towards much more accountability. And so we're constantly seeing reports, you know, in early or late fall, I guess, there was a report about coding and upcoding and changing diagnosis levels for MA plans and members to get additional dollars. Just yesterday, there was a release by OIG about a report of MA plans who were not providing medically necessary services to beneficiaries or approving them and denying claims in some instances for services that had been provided. And so there's this additional emphasis of compliance and regulatory oversight the government's putting on it. And so I think they're trying to weed out who wants to be here, because there is a lot of movement, and who are the right people to be doing this. And then how do we all integrate? You know, the emphasis on the payer, the organizations who can bring the infrastructure, and then the providers, and how does it all coordinate to ensure that continuum of care for our patients, and that they get the best quality, the most efficient pricing, and that it does come full circle.
Robert, you have, your company raised a lot of money.
Yes.
And I'm sure that everybody who's contributing the money, they just didn't do it because they're nice guys and wanted to just give you a handout. They're expecting.
No, that was why they did
it. They're expecting to ultimately get something back. So my question is what are you telling them in terms of the way your business runs that makes them feel like they want to make that kind of investment?
Well, so I think, again, what you're hearing, and anytime you got a disruptive technology, there's all these great ideas, and some consultant or somebody can map out the end game and what it looks like. And typically the end game is understated as to what it'll eventually be in the long term, but it's in the near term, it's overstated. So you have to get through. And then a lot of what we're talking about comes back to, okay, great, this is a wonderful idea, we buy in. How do we actually pull it off without losing our shirt and without, affecting the care or taking our company down? So a bit of a long-winded answer, but so we are focused on execution. We have the analytics, we have the networking capabilities, we have the pricing capabilities, and we have the platform, but we have to execute. So we're out there working with payers and providers, primarily payers right now, to put in effect instances where we can go out and here's a use case for maternity, and we can show where we have done 837 episodes, deliveries, and the shared saving or the savings is in the $8 million range, and we can document that. And that, you have to show 2 people how to do it, 2 people show 5 people, 5 people show 10 people, and all of a sudden it becomes something. So, and again, I've been around disruptive technologies. It looked really good, but you have to get to first base before you can start rounding the bases. So it's house to house. So you have to do it, and you have to execute, and you have to be very careful, and you have to be very transparent. And then I think then underneath that, again, that may all be very obvious, but then underneath that, you do need to build a technology platform. 25 years ago, people said it would be great to take people that want to sell something and combine them with people that want to buy something. So sort of a technology-driven way to make money was to build eBay. And it was this platform that allowed sellers to put stuff on there and allowed buyers to then interact with them. And they built another company along the way to facilitate the payments going back and forth called PayPal. And a guy named Elon Musk that I think's been in the news recently made a little money off of that. But again, these were fundamental ways that you had to, or even if you look back at the internet, why did the internet proliferate? Because there was a standard. And as you said, this has to be open where people can, the systems can talk back and forth. And unfortunately, you have a lot of resistance. You might have a big technology provider out there right now that services a lot of hospitals, and they may like the fact that they have a closed system. I won't name names, but so that's got to open up. And so you have to be able to share the information in a protocol that is HIPAA compliant and fast and reliable. So a lot of the fundamentals have to go in there. So hopefully that made sense.
And Mike, I would add, I think CMMI's recognition of the importance of data exchange and integration in their most recent white paper and their strategy and their vision of making sure providers are at the table and really including them in the conversations, but also finding ways to help that data integration is going to be key.
I give CMMI a lot of credit for continuing to push this and not stop.
Yeah.
Ed, you've been talking to a lot of clients and about to be clients about the whole idea of value-based enterprises. And I'm curious as to what kind of questions and thoughts are you getting from the people with whom you're talking and about what they're looking to achieve?
We're hearing a lot of different things, and I think there's a lot of interest in pursuing and moving down this corridor towards risk-based contracting. I think it's because there's another opportunity for returns. And to the extent that providers can help create efficiencies and higher quality of care, that's a purpose I think folks generally all agree with. But I think we're hearing a lot about primary care. How can primary care participate and be a foundation? One of the things, you got to have substantive things that the primary care physicians are doing, but through the continuation of, coordination of care, there may be a lot of places, but also when you're creating evidence-based medicine and protocols, you need the clinicians engaged in that. And so engage them through the whole continuum of care, is one way. Another thing and there can be opportunities to participate. I think one of the things we've noticed in chatting that, not all the physicians are, they're busy practicing medicine, but occasionally you'll find an entrepreneurial type that has created the IPA or created the ACO or is trying to head up this or that. And when you create these conglomerates of providers around a value-based enterprise, those entrepreneurial type physicians can be coming into the mix, through the ACO or the MSO or their IPA and be a vehicle for further, helping to care, manage care and coordinate care. And we're seeing that in the way, contracting goes with direct contracting entities, the individual providers or management companies or MSOs, whatever you want to call them, to the extent they're good at leveraging another layer of providers, they're negotiating more for what they're doing. And that's the end game. You bring more value to the proposition, then you should be able to negotiate more returns. And I think the other thing that folks like when they, the classic Stark rules allow you to, health systems have done this for some time, you can restrict, require that the participants, restrict their referrals within the system. And that makes good sense for economics in healthcare. If you're going to invest in the hospitals and your physician networks and all that, you want that work coming back to where you built the infrastructure. You can use those same rules here with a value-based enterprise. And that makes sense too, because if you're all working on the same value-based protocols, then you don't need to be sending the patients off in different directions where they're not having that same work done when you're trying to create an outcome for the payer. So, I think we're hearing more about how can people participate. And once they do participate, you can have it, the requirement, we're going to be exclusive within this value-based enterprise. Patient choice is the big exception. Medical needs of the patient being better served somewhere else or the other. But I think there's just a lot of people trying to understand it and try to understand how can I get involved. And I think that's also a reflection. People see this change coming. And I go back to the basic proposition. Do you want to sort of take control and drive towards this future and try to leverage your position, or just sit back and wait till somebody knocks on your door and says, okay, will you participate in this program with us?
Thank you. Ed and I have only been working together on this for a little while, but it seems like we've been working together all our lives. It's really been, I just wish we'd started about 10 years earlier. But I have to just tell you personally, I think back, I really made my mark. I got into this business by becoming a cat herder. And what I mean by becoming a cat herder is that I took small groups of physicians in specific specialties, not primary care, specific specialties, and grew them into big groups. And they still had all their little care centers that they had before, and they still competed each other like they always did, but they were part of a one big group. And we did that primarily to be able to legally, collectively bargain with managed care companies. And it worked most of the time. And then as an aside, we also would put together ancillary businesses that because of the changes in the law, we couldn't do anymore unless we did them through a group practice. It's just not the case anymore. I mean, most of those practices, by the way, many of them got sold to private equity for lots of money. But private equity isn't using them anymore to do what they were originally set out to do. Now they're having to focus more on value-based care. And some of those private equity companies will continue to make a lot of money, and some of them won't. And we will see down the line exactly what happens. But it's just thinking to myself in a relatively short period of time, how the whole world in healthcare has changed. The only thing that hasn't changed, it was messed up then and it's messed up now. And I don't know how that's going to be set, but certainly the push towards value-based care is not going to end. I'm just looking. We do have a few more minutes. Does anybody have any questions? I'm expecting lots of questions. Yes. Yes, sir. Here, you know what? I'm gonna come down here and I'll let you speak on this. Make sure I don't fall off. When I walk down, it's dangerous. Okay.
Ganesh Arora from Florida Accountable Care Services here in Winter Park. Question for Ed White. Attorney White, you mentioned that we got to target a patient population. For example, can one of the patient population we target could be oncology patient population? Because we find there is a fragmented care in oncology population. Patient seen by primary care doctor, coughing blood, chest X-ray done sometime in the office, sometime in a diagnostic facility. By the time he's seen by pulmonologist, and he orders CT and he does biopsy, PET scan. All this testing are done elsewhere. By the time he's seen by the oncologist who is need to manage, he doesn't have all the pieces. I would imagine analytic or software like Robert is talking, who could integrate from patient seen by the primary care doctor, his notes, his chest X-ray, his CT scan report, biopsy report, PET CT report, genetic, all done at one place for oncologists to tell the patient, hey, I can see what's going on. You got adenocarcinoma, I'm going to offer surgery followed by chemoradiation. If he doesn't have all the pieces, he cannot coordinate that care. So when we say care coordination is one of the things we could do in VBE, are we talking about coordinating care for that particular incidence where we make sure all the pieces are there and one entity is coordinating that care for that patient?
The short answer to your question is you have, under these new rules to fit within these exceptions, you have complete flexibility to define your target patient population. You need to do it in advance and in writing, and your activities that are serving in that patient population are the ones that are protected. But you can be, you can be as broad or narrow as you choose to be. Obviously there's economics behind that, but you have complete flexibility.
So who takes the responsibility of coordinating that care? The value-based enterprise may be owned by some investors, some physicians, and the referring doctor who is not part of the VBE, he's saying, I'm sending the patient, I'm not responsible on your VBE, whether you succeed or not, whether you take care or not. And that is question already been asked from us. So is the VBE totally responsible for that care coordination?
Let me say it another. I think I understand. The VBE sets its scope of its activities and its purposes.
Right.
And then the providers that choose to participate, just like an ACO, they come in and they're agreeing to perform certain standards. So whatever you however you cast that net and envelop the activities and the providers, and if the primary care hadn't been brought in, then they're not a part of that. But if you bring primary care in at some level and they have a role, then they can be, when you say responsible, it ultimately means, are you getting compensated for helping?
But the VBE might be, it might be an ortho practice that has their own standalone facility.
Yep.
And they decide that they're going to be the VBE for knee replacement because they have the docs to do the operation, they have the PT to do the follow-up, they've got the facility to do all the operation. And then they will get one check, and then they will take care of the anesthesiologist and the radiologist and the PT and the facilities all underneath that. So the concept of a VBE, at least in our world, it could be a provider group, it could be an independent finance group doing it. It could be in some of the relationships we have, it's a big payer, and they're going for value-based care bundles, but it's still ultimately they are the plan, and they're the ones that are managing downstream. We're working on one right now where they literally said, go out and recruit the providers, and we will get the price with them, but we will take care of all the downstream. And whether they're going to take care of it in a value-based care, episode-based model, bundle model, or in a fee-for-service, they just want to get going so that they're not waiting for it's that old perfect is the enemy of the good. If they can handle 80% of this episode in a VB, in a value-based care bundle payment and the rest in fee for service, they'll do that. Does that comport?
If there are not other questions, I got one myself. Yes, sir. Let me bring this over to you, sir. Thank you.
How do you scale evidence-based protocols across the enterprise? And how do you make sure that with all the changes that happen, how do you make sure that they stay current?
So a lot of people in different places throughout the system who are coordinating, meeting frequently. We have our PHSO, so our Population Health Services Organization, has a case management team who aligns with our hospital case management team, and they coordinate care together, they coordinate programs together, they coordinate on different initiatives. We have a team of clinical excellence leaders throughout the company, and they are charged with ensuring that whatever models we're working through and what we think looks and feels good actually does fit within the operational structure that's in place. And so we have a chief medical officer in the PHSO who coordinates very much with our system chief medical officer and clinical leadership to make sure that all of that is happening and that it's happening real time. Because as we're seeing constant changes, especially when you deal with telehealth and virtual care, and plugging that into the cog of the care continuum wheel of making sure that we're all coordinated in the right way and providing the services as they need to be.
It's my pleasure to introduce the last panel, Gabe Imperato and Donna Beeshold. What can I say about Gabe other than, you know, what you don't know? I mean, okay, I'll do it.
Don't do that.
I've learned at my age.
Wait, Mike.
No, you're not interrupting me. I have the microphone. I've learned in life that life is all about choosing partners. It's true with your spouse. If you want to win your golf bet, you better have a good partner. And it's particularly true in the practice of law. And I was fortunate to be partners with Gabe in 2013. And so I think I picked a good one there. Donna Beeshold is also a great partner. Donna actually has Central Florida roots, although she is resident in our Atlanta office and has been working there with Northside and some other hospitals. Donna is a product of Lake Mary High School. So with that introduction, two great partners, Gabe and Donna.
Thank you. Well, Mike, I appreciate you saying that. You know, when you get to the point where you're closely approaching advanced age, you appreciate those things a little bit more. Okay, there's our pictures. Okay, so we're going to talk about compensation arrangements where you don't have the benefit of fitting into the exceptions or new exceptions that Ed and Mike and the panel were just talking about. Okay, you fall outside of them and you end up running in violation of the Stark Law or the anti-kickback statute, which of course have these particular concerns. I'm not going to go through every slide or every line in every slide, but just try to hit the highlights. What I'll say here is that, you know, violations of the kickback statute or the Stark Law can be brought through the False Claims Act, and False Claims Act liability can be predicated based on a violation of those two laws. And why is that important? Well, take the Stark Law, for instance. CMS has really never affirmatively enforced the Stark Law, even though they have primary jurisdiction to enforce that law. I think they also have an advisory opinion process, of which they've issued 2 advisory opinions in 25 years. They have a self-disclosure process that they essentially have ground to the ground because there's too many self-disclosures, and now they're basically getting rid of them all without liability. And now they've developed the value-based exceptions to the Stark Law, which if you carry it out to its logical end, and if providers move into that space, will almost make the Stark Law a statutory anachronism. But it's the whistleblowers under the False Claims Act that have created the liability under the Stark Law, because they've premised False Claims Act liability based on the violations of that law. So and also the kickback statute. But the two statutes are a little bit different. The kickback statute requires an intent-based element. You have to knowingly violate the kickback statute. The Stark law, on the other hand, is not an intent-based law. It's a strict liability law. So you're either in or out. If you violate the Stark law and you don't fit into an exception and meet all the criteria in the exception, then you're violating the law. And whistleblower counsel love that because they can figure out many ways to allege that you're violating that Stark law because you don't fit into an exception, and therefore you're submitting claims premised on compliance with the Stark law, but you're not in compliance, and therefore those are false claims, and now you've hit the promised land as far as they're concerned. So let me move ahead here. And when we take these two laws and we apply them to our compensation arrangements, we have a whole series of cases that have arose over the years. And they've involved a number of different theories of liability. We'll talk about Halifax. Prior to Halifax, probably the first case, a whistleblower case, was called the Kaczynski case. And it was in Pennsylvania. It involved a hospital that had a traditional contract with anesthesia doctors who had an exclusive right to provide anesthesia in the operating room of the hospital. In that contract, they had a right of first refusal to basically provide outpatient care if the hospital ever created an outpatient unit in the hospital, like a pain unit, pain management unit. Well, eventually the hospital created that, and the anesthesiologist exercised the right of first refusal to staff that, and the hospital provided all the supplies, the space, the personnel, and everything to support that outpatient service. And of course, the anesthesiologist provided the professional services, but kept all the income. Well, a whistleblower who actually, I think in that case, might have been a physician who didn't get the benefit of that right of first refusal, alleged that the hospital providing all that benefit to the physicians was a form of a kickback and or a violation of the Stark law because they were covering all their overhead, all their personnel, and everything. And that case got traction, and then we were off to the races on these whistleblower physician compensation arrangements. And the next really big seminal case was the Halifax Medical Center case. And besides the fact that it resulted in an $85 million settlement for the hospital, there's a couple of morals to this story that I think are important when we talk about this risk and managing the risk. In this case, you had like 6 oncologists who performed personal oncology services, and then if their patients needed chemotherapy, they would refer them to the hospital for chemotherapy. And the hospital structured the compensation arrangements with the oncologists, and they were employees. It was an employment relationship where they would get a base salary, and that base salary was definitely within the range of fair market value, which is a requirement. But they would also get a bonus, quote, based on their personally performed services out of a pool of money that was created by their referrals to the hospital for chemotherapy. Not the whole pool, but a portion of that. Now, there is an exception to the Stark law for employment arrangements, and they were employees. And the exception also requires that their compensation be consistent with fair market value and not be based on the volume or value of referrals, except they can get a productivity bonus based on their personally performed services. So the hospital, in creating the bonus pool here, said, okay, at the end of the year, we're going to divide up this pool and we're going to give it to you, the 6 oncologists based on their personally performed E&M services that they billed out for their professional services. Do you understand that? So here's the pool. Oncologist 1 did 30% of the personal performed services over the year. They're going to get 30% of the pool. Oncologist 2 did 10%. We're going to give him 10%. And so in the hospital's mind, they figured they were complying with the employment exception in divvying up that referred income in accordance with their personally performed services. That was in 2008. I probably would have given the same opinion at that time, okay? Only the opinion was based just on reading the statute. There was no case law and nothing to really rely on for that opinion. Well, an employee of Halifax who was the director of physician services, who wasn't a lawyer, went to conferences like this where people were talking about the Stark Law, and she went back to the hospital one day and she was like, you know, I think we're paying these docs based on their referrals for chemotherapy to the hospital. And she raised it with the compliance officer and with the general counsel of the hospital. And the general counsel of the hospital at the time decided, well, you know what, let me go out and get a legal opinion about whether or not this type of compensation arrangement is consistent and is legal under the Stark Law. So the hospital went out and got a legal opinion from a nationally recognized law firm. And the opinion was, like most legal opinions, close to worthless, but it basically said what I would have said at the same time. It said, it's reasonable to interpret the law in such a way that the compensation arrangement to the physicians, because you divvied up the pool based on their personally performed E&M services, is compliant with the Stark Law, but we can't give you complete assurances. We're not sure what a whistleblower's view would be or the government, but that's our reasoned opinion. And with that, the general counsel decided to continue paying the doctors. Well, the individual who was the director of physician relations there was like, I don't know, it still seems to me like it's a violation of the Stark Law. And she really wrung her hands about this for about a year. And she had consulted with counsel, and counsel said, you know, I'm ready to file a case when you're ready. And she wasn't ready for about a year. But finally, one day she said, I just think it violates the Stark Law, and go ahead and file a case. Case was filed. The government didn't have a big interest in the case at the beginning. They declined to intervene, but her lawyer was fairly sophisticated and knew how to move these cases forward on their own, and did, and then engaged in discovery. And eventually, the government came back in because discovery kind of fleshed out some things they didn't know before, and they came back in, and it was a heavily litigated case, and it went to the point where there was a motion for summary judgment filed by the hospital. And in the context of that, the issue about the Stark Law was put in front of the judge. And essentially, the court had to consider basically whether they agreed with the legal opinion from the law firm that was given to the hospital. And guess what? The judge said, you know what? I don't think that's what the government contemplated when they made the exception. And really, you're paying the physicians based on their referrals, okay? And at that point, the hospital knew that they were going to have to go to trial. And if you know anything about this area of practice, you don't really go to trial in a False Claims Act case before a jury, okay? And they ended up paying, $87 million. I think the moral of the story of the Halifax case is, for these issues, you don't address these issues with legal opinions. you have to assess the risk of becoming on the back end of a whistleblower case. And if there's any doubt about the application of the law in a particular context, you have risk because, you know, the government kind of protects whistleblowers. They kind of make it easy for them to come forward to obtain recoveries. And once that complaint is filed, you're on the merry-go-round. If you have to deal with this issue outside of the context of your own compliance program in a whistleblower context, you're looking at, instead of spending $100,000 to make it go away, you're going to probably look at $500,000 to make it go away, with reputational damage and other fallout that comes along with these cases. And that was really, to me, was the moral of the story of the Halifax case. The Toomey case, which you've heard us talk about, our firm was materially involved in this case in a number of ways, more or less after the fact, and helping them try to deal with their judgment. The moral of the story in the Toomey case was, I think, basically bad advice, who didn't recognize what the risk was in the circumstance as it was presented. I mean, I'm not even sure that you have to look at this case in hindsight to realize that there was risks involved. And I know Ed White left, but I know, oh, there's Ed. Ed was actually consulted about the arrangement that Toomey ginned up because he was representing another hospital in the community, and they kind of came to Ed and said, you know, I think Toomey is doing X, Y, and Z. And Ed's response was, boy, that doesn't sound right to me. I don't think that will fly. Well, Toomey didn't get that advice, and they went ahead and so be it. This is a North Broward Hospital District case. This was simply a case where the hospital had no mechanism for tracking their physician compensation arrangements, and certainly no procedure for ensuring that their payments were consistent with fair market value, and that they met the requirements of the Stark Law or the kickback statute. And interestingly, in this case, another physician was the whistleblower in this case, and they ended up settling for $70 million. We had to come in on the back end of this case and clean up the mess that this created back in 2019, because it really caused a lot of disruption to the hospital, a lot of expense, and a lot of reputational damage. These are just some examples of different compensation scenarios that exist in this space. You have stacking arrangements. We call them stacking arrangements, where a physician in a hospital will have various different kinds of compensation arrangements with the hospital. Maybe they're a medical director, maybe they're employed for professional services, maybe they're performing other functions, but they're not tuck and tied correctly, and they fall out of compliance with the Stark Law, the kickback statute. And then we have Stark violations that I refer to as technical, in that they don't meet the criteria for being a written agreement, or for being signed by the parties, or for being renewed when they expired. Now, these are technical violations that don't really make the best whistleblower cases, but they certainly have caused a lot of compliance angst amongst hospital clients. The moral of the story is that you kind of have to understand what the risks are, identify them when they arise, and hopefully they arise through your compliance program in an organization, and you can deal with it internally as opposed to having to deal with it externally, and manage that risk accordingly. You know, because of the whistleblower phenomena in healthcare, we really are operating in a fishbowl. It's not like you can assume that somebody isn't going to detect these non-compliant activities, okay? And once they're detected, your organization is in a race to the courthouse with a whistleblower. So you really have to be on top of these things, make sure you understand when something is occurring that poses risk, and manage the risk accordingly. And this can occur in many different sectors, including real estate. Donna.
With that, may I? Thank
Sure.
you. I'm going to go rogue and go off camera over here so I can see better. So for those of you who don't know me, my name is Donna Beeshold. I'm in Atlanta. I specialize in healthcare real estate. So my practice focuses primarily on representing hospital systems in leasing arrangements and development transactions. So I figured it would be helpful to look at a few scenarios where real estate comes up in healthcare. So we're going to be looking primarily at the space rental safe harbor, as well as two of the primary Stark Law exceptions that we structure real estate transactions under, which is the rental of office space or the timeshare arrangement exception. So this is going to be an overview for many of you in this room, obviously, but the anti-kickback statute, when we're structuring for a real estate transaction, we're looking for it being set out in writing, covering all of the premises, specifying that premises, meeting that 1-year requirement, as well as a set in advance requirement. But in terms of compensation on the real estate side, rent, we're looking for it to be consistent with fair market value, not determined in a manner that takes into account the volume or value of referrals or other business generated. But we're also looking for people not leasing more space than they need to accomplish their commercially reasonable business purpose of that rental. On the Stark Law exception side, we're looking at two primary exceptions. These aren't the only exceptions that are available, but these are the ones that we rely most heavily on. So the rental of office space is really our bread and butter. A lot of similarities to the anti-kickback safe harbor, 1-year requirement set out in writing. We do have an exclusivity requirement, so the space needs to be leased exclusively by the tenant. This is one of the clarifications that came out in the most recent 2021 ruling and the commentary that went along with it. This requirement in particular is to the exclusion of the landlord or anyone associated with the landlord. That was a clarification that was particularly important on the leasing side because we had a lot of arrangements where you lease an entire building, you sublease back a portion of it, or you lease back a portion of it, and that was actually specifically called out in the commentary as being a sham leasing arrangement. So that was an important clarification to be made. But then in terms of the timeshare arrangement, we use this less often only because it has a lot more restrictive criteria. One of the benefits though is it is able to extend to things other than real estate. It can extend to equipment, personnel, supplies, which, you know, instead of structuring a real estate arrangement under multiple different exceptions, if you do have things like personnel involved in your arrangement, this really provided a lot of flexibility, especially for hospitals. But there are some very important differences. You know, this arrangement can only be between a physician and a hospital, predominantly for E&M services. The equipment has to be in the same building, so there are restrictions in that regard, and you can't use any equipment for furnishing DHS unless it's incidental. But on top of that, and more importantly, on the real estate side, that arrangement is not able to convey a possessory leasehold interest. So from a real estate perspective, what does that mean? You're allowed to exclude others from your space when you're granted the ability to utilize it. That's an important distinction because from a real estate perspective, that may not be attractive to physicians who want their own particular space at their own particular times. And this is more of a fluid transaction if you're structuring it under this exception. Important to note a few things that came out from the new final ruling. There is a very specific definition of fair market value for real estate arrangements in particular. Substantively, it's not very different than what our definition was for fair market value before. Same with general market value. Really, we're looking for a transaction where it's at arm's length. It's not taking into adjustment proximity or convenience to referrals. It's consistent with general market value. And what does general market value mean? It's basically the price that you would get if you were negotiating with parties who are not in a position to generate business from one another. In the interest of time, I'm going to skip over these case examples so we can get to some of the more practical examples that come up on a day-to-day basis. Really, our compliance pitfalls on the real estate side are going to come up with short-term arrangements, holdover, fair market value concerns on the rent side, off-lease benefits, so really anything outside of the four corners of your document that's being offered as an incentive, changes in space or remeasurements throughout the life of a lease, and then timeshare schedules. So I figured it would be helpful to go through a few examples so you can see how this comes out in application. Our first example, we've got a 3-year lease term between a physician and a hospital. At the end of the lease, a physician holds over for 7 months. Seems harmless. The holdover in and of itself is not the concern. That's permitted. There are no restrictions. From the latest final rule before this last one, there was a 6-month max for holdover that has fallen away. So that is not the concern. The concern comes into play what happens during that holdover occupancy. You have a new leasing arrangement in essence, but you're going off of the existing lease that was in place. So oftentimes people want to change the lease terms during that holdover occupancy, but it's important that you strictly follow the terms of the original lease. If you modify a financial amendment or a financial term during that holdover occupancy, it can be perceived as a financial amendment. So with that, holdover rent is probably one of the more common examples. Usually we have 125% of rent for holdover rent, 150%. It's important to pay very, very close attention to the language of the lease. If it says landlord shall charge holdover rent, you have to charge holdover rent. If you deviate from that, you are doing a financial amendment to the lease because you are choosing to charge them less. If it says may charge holdover rent, you've got a little bit more discretion. Maybe you don't charge them the premium rate. It's all going to depend on the circumstances, but even under this instance, if you're dealing with a holdover situation, we do want to document that in writing. Operating in a holdover scenario where it's undocumented can get into a very gray area where you have to rely potentially on the state law for holdover occupancy, evicting a tenant. It gets very, very messy. But at the end of the day, if you document, we usually do holdover letters to say you are going to stay for this particular period of time. Here's the rent that you're paying. Resolving that ambiguity can only be helpful in terms of compliance. All right, example number 2. We've got a hospital landlord and a physician tenant in a building that's owned obviously by the hospital. They negotiate terms which are ultimately more favorable than the terms offered by that same hospital to other tenants in the building. Rental rate is lower, more favorable terms overall. What's the problem here? Really, it may not be a problem, but it's important to note that you are only permitted as the landlord hospital to charge rent that are consistent with fair market value. Obtaining a fair market value report is the best practice to ensure that you are operating within those parameters. That's going to give you an idea of what's going on in the subject market. And it's also going to give you the tools to approach a scenario where if you're offering something like the ability to operate a mobile imaging center in the parking lot of that building, that's typically perceived as an additional value offered to a tenant, which may carry additional rent charges. And if you're offering it for free, you may be, getting yourself in trouble there. Receipt of the fair market value report alone is not going to be enough though. So while it's a tool, it's not an absolute tool, but it's a tool and a step in the right direction to establishing that you are charging fair market for your lease terms. It has to make sense. It needs to account for the terms of a transaction, the subject market. Ultimately, if a transaction were to ever come under regulatory scrutiny, the idea is having that fair market value report in your records is going to help withstand regulatory scrutiny. So if you have a fair market value report and don't review it, for example, it may actually contain explosive information and be the worst thing that you could possibly have in your records. And that is sometimes a hard pill for people to swallow, given the amount of money it can take to generate these reports. But ultimately, it is widely recognized as being a useful compliance tool, according to CMS, for evaluating fair market value.
Donna, I would say that if you had to defend a compensation arrangement or a real estate arrangement against an allegation of violating a kickback statute and historic law, and you don't have an independent fair market value report documenting the fair market value of the arrangement, you're going to be at a significant disadvantage. Yeah.
Right? Absolutely. All right, let's look at example number 3. This comes up a lot. So we've got another leasing scenario. Space next door to a tenant is vacant. They have stuff they want to store. They go to the landlord and say, hey, can I store a few things in the space until you lease it out? Problem. You're not going to be able to satisfy the fair market value requirement and arguably the commercial reasonable requirement. You're essentially giving free rent to a tenant in order for them to store equipment or whatever it might be and utilize that space. So that doesn't mean that you can't enter into a leasing arrangement for storage space, but you need to be able to do it on, in compliance with the various requirements, one of them being consistent with fair market value. I would be hard pressed to find an appraiser that could go out and say that renting storage space is for free is totally representative of the market. Now, it is important to note, though, that on a storage space lease, this is very different than our normal medical office leasing. You do need to be careful to comply with all of the other requirements as well as the anti-kickback safe harbor. So it's just an important consideration to keep in mind, even though it's a simple storage lease, that doesn't make it necessarily exempt from all of the other requirements. And again, it's a strict liability statute. So it's important to comply just like any other leasing arrangement. Example number 4, our second to last. So we've got a physician tenant who's leasing the entirety of a medical office building from a hospital landlord. During that arrangement, tenant decides that it no longer has a need for the entire facility. Hospital has a need, so it offers to sublease or lease back that unused space from the tenant. This is a problem, especially in light of the latest commentary from CMS about these sublease or lease back arrangements. This is not going to satisfy the exclusive use requirement of the Stark rental of office space exception. It's very likely that it would also not satisfy the legitimate business purpose exception requirement of the exception as well. It does beg the question, if you entered into a leasing arrangement for 4,000 square feet and you only needed 1,500, why are you leasing 4,000 square feet? And then leasing it back to the landlord who may or may not actually have a need for it. This is why this shell of a leasing scenario has been specifically called out by CMS as a highly suspect arrangement. What could you do depending on the timing of when this issue comes up? If you're after the first year of the lease term, remember 1-year term minimum under this exception, you could negotiate an amendment, remove the unused space from the premises, because again, the tenant obviously doesn't need it, and you would adjust your financial terms accordingly. If you are prior to that 1-year mark, or you are within 1 year following another financial amendment, typically under this scenario, we would recommend that you terminate the lease entirely. That does not mean this hospital could not lease other space to this tenant in another building or different space, but it is important to keep the optics in mind. For example, if they leased 4,000 square feet, tenant said they didn't need it, okay, fine, we'll terminate the lease. You wouldn't want to go and put that tenant in 4,000 square feet in a different building. It's also important to note that if you are amending the lease to remove certain space, so you're just keeping a portion of it, that space, what's remaining and what's being kept, needs to be separate and distinct from one another. So you can't have an open sharing situation of space if you're on the same floor, for example, because again, this exclusive use requirement would prevent the parties, landlord and tenant, from sharing any sort of space under this exception. Our last example is a timeshare example. So we've got a timeshare arrangement, very common, in a new market. The tenant physician is unsure if there's a market for his services out in this location. So he wants to start out using the space twice a week for only 6 months and determine the exact schedule, you know, later on when they figures out if he actually needs the space. This is where the two stark exceptions that I talked about earlier are going to come into play. If you're structuring a timeshare, two primary exceptions, we've got the rental of office space and you've got your timeshare license exception. This arrangement, it being 6 months, would not be permitted because of the 1-year requirement under the rental of office space. It also wouldn't satisfy the set in advance requirement, this type of flexibility that they're looking for. However, 6-month arrangement, flexibility in setting your schedule, there is a way to structure that under the timeshare license. Typically, if we can meet all of the criteria of the timeshare exception, this would be the stronger option for the parties to consider. But again, there are additional criteria that need to be met in order for this exemption to be available. You also need to make sure that there is a commercially reasonable mechanism for setting that monthly schedule, because it's still recognized that if you are modifying a short-term arrangement multiple times, it is considered suspect. So again, what Gabe touched on earlier, we are trying to avoid a scenario where we're put under a microscope. So even the appearance that you're doing multiple modifications to an arrangement could potentially attract attention that is unwanted. So some practical takeaways on the real estate side. I'm not going to go over all of these, obviously, there's a lot of information. But from a hospital's perspective, we typically approach these transactions by assuming that Stark law applies, unless there are very, very specific facts to say that it doesn't. That is going to help with the efficiency of creating your compliance protocols as well. So you're not evaluating every single transaction in a vacuum. Sometimes it's warranted, but when you have a large volume, which most hospitals do, approaching these transactions from that lens is going to lead itself in a positive direction. But putting in place those compliance protocols and those trainings is also an important part of compliance, especially from the hospital side. If you are able to put those in place and then follow them, it's going to streamline the process for lease administration and management. On that note, establishing a good practice for fair market value reports and opinions is equally as important as any other component of a training and compliance program. Typically, what I recommend for my hospitals is that we set up an annual FMV process. And what that does is we set out and target the markets that they operate most frequently in, the building, where their buildings are, where their hospitals are, where there's, you know, medical office development that's exploding in the market. We go out annually and get fair market value reports, so we have the exact parameters that we know what we're operating in. So if a transaction falls outside of it, and that happens, we have the ability to say, okay, we need to go and pursue a special lease specific FMV report to justify operating outside of the general market data for that particular market.
Donna, who do you get to do those real estate fair market value?
I use National Valuation Consultants. They're a company that I've worked with for both Orlando Health and for Northside Hospital. And what we do is we establish a form. Legal reviews the form of FMV that they utilize, and we can make sure that the definition of fair market value is correct. They're looking at commercially reasonable criteria. we can give them the guidelines of what we're looking for in a fair market value report. And it also streamlines the process. When you get that fair market value report back, you know exactly what's going to be in there because you've told them what to go and look for. So it's a very effective tool, and it's actually a really great cost saving measure as well. Because when you order 6 to 8 fair market value reports for your biggest submarkets, when you're negotiating LOIs or leases on the front end, you know exactly the criteria that you're operating within. So from a relationship standpoint as well, when you're negotiating with physicians, you don't have to say something and then legal come in and say, hey, you can't do that, and then have to go back and create more of a headache. It really does streamline the negotiation process. Commercial reasonableness. This was a brand new codified definition from the latest regulations. Previously, it was not defined, and it caused a lot of ambiguity as to what was commercially reasonable. And how we previously dealt with this, we looked at the market data, we dealt with it very heavily, relied upon fair market value reports to see what was going on in the market with other hospitals, with other physician groups, to see what's normal, what's commercially reasonable, and what is outside of that. The evaluation has gotten a lot more involved. The questions that we're asking to evaluate commercially reasonableness are different than just looking at objective data. So it's important now, based on the latest commentary, that we are evaluating this requirement at all salient points of a deal. So you're not just evaluating it like fair market value at the inception of a deal. You're looking at it when you enter into the lease, when you're up for renewal, when you go to an amendment. It's got to be something that's in the forefront of any hospital's mind when they are tracking and monitoring compliance, because something could change at the drop of a hat. And we're not just looking at objective data anymore. We're looking at the parties, the type of transaction. There's a lot more factors that we're looking at now from a compliance perspective to evaluate this requirement. And with that being said, because this is a new codified definition, there's going to be adjustments that have to be made as new and additional insight and commentary comes out. Written communications, this was another point that came up from the latest commentary, and I wouldn't say it's new, it's just been clarified. Be very, very careful about informal communications, texts, emails, about leasing arrangements. Had a client get into a lot of trouble about a text message string that went back and forth about the reason why a medical office building was being sold and the relationship with the doctor. It can lead to some pretty hairy situations.
Yeah, emails count.
Space measurements. A lot of people don't realize the difference in square footage that a simple measurement technique can cause. Usable versus rentable square feet, who's doing your floor plans, how accurately a space is described. And this is a requirement of both the anti-kickback statute and also the rental of office space exception among the timeshare. Accurately describing the space and making sure it's all of it. These are important considerations. And then the final point, I'll say, savings clauses are a very important tool that we include in all of our leases and lease forms that we create for our medical providers and hospitals. And it's basically your nuclear option. So if you find yourself in a situation where your lease is not compliant or something has changed to where something once was compliant is now in a gray area and it's exposing you to risk, this is the ability for the parties to meet, confer, try to fix it if they can. If not, terminate it and get it out of existence. It's something we always put in our leases. I personally have never had to rely upon it. It's always a lot of the fact gathering on the front end, but if it's unavoidable, this may be your lifeline.
Okay, thank you, Donna and Gabe. So for those of you applying for CLE, this is your last code word. Collaboration. Collaboration is the code word. Collaboration. So with that, I would like to thank all the attendees, both those in person and virtually. I know from experience how disruptive it can be to your ongoing schedules and all your responsibilities. So thank you all for showing up and interacting with us. Thank you. I want to thank our presenters and my partners who traveled quite far in some instances for being here. But lastly, I want to thank the lady who's standing in the back, Jocelyn Adams. Jocelyn has done enormous work keeping us on track and putting all this together. Jocelyn, thank you very much.